Ms. Rosapepe.
He says he's in.
Okay. Good afternoon, colleagues and members of the public. The Senate Finance Committee is now in session. We have 7 bills to do this afternoon, and later we will be voting. The bills are in the following order. Senator Rosapepe, Senate Bill 741. Senator Edwards, 621. Senator Augustine, 638. Senator Hershey, 541.
I'm connected. I'm clicked on.
Senator
Maybe
Reedy,
I got my sound down.
614. Senator Reedy, 615. And finally, Senator Kagan, 580. Okay, and so we're ready to start now with Senate Bill 741, COVID-19 testing, contact tracing, and Vaccination Act of 2021. Once the bill sponsor has completed and they have as much time as they need, then we will go to the chief proponent for the bill, and that person will have 5 minutes. All other witnesses with oral testimony will have 2.5 minutes. So Senator Rosapepe, you're on.
Thank you very much, Madam Chair. And a pleasure to be with all of you. This is a big bill on a big problem, which we're all familiar with. Dealing with this pandemic on the health side requires a lot of moving parts. And we've seen over the last year, some of the moving parts have moved well, and some of the moving parts have not moved that well. And so together with my colleague across the Raul Boulevard, or across the hall in the State House, Delegate Jocelyn Peña-Melich, the Vice Chair of Health and Government Affairs, she and I have been working over the past 5 or 6 months with our staff at DLS who handles healthcare, with the state health department, with the local health departments, with the hospitals, with all the variety of folks who work in healthcare, to put together a framework to try to guide the state over the next 2 years, meaning 21 and 22. We're all very thrilled that vaccinations are coming here. But even if vaccinations go better than they've gone in the past few weeks, which they will, I think, we're going to still need a lot of work and a lot of organization the rest of this year and definitely into next year. Therefore, the bill is designed essentially to say, look, we need clear plans, clear flows of money, clear goals in those 3 areas: testing, tracing, and vaccinations. There are a lot of details in the bill, which I'm happy to come back to if folks have questions. But the essence of it is to require the state to work with everybody to come up with plans that everybody understands what they are. One of the problems last year, as you know, was the federal government didn't have its act together, gave conflicting information, all kinds of points. And frankly, the state health department has done a good bit of that in Maryland too. We've had lots of complaints from the local health departments and others about that. So basically the bill is designed to provide a framework. It's designed to direct the huge resources we are getting from the federal government and will get from the federal government in a coherent way. Let me just stop there. These are lots of details if anybody wants to go into them. We have been working with all the stakeholders on their concerns. Unlike the other bills I bring before the Finance Committee, this is not perfect as introduced. And so some of the witnesses have some very constructive suggestions. And I also want to say that I've been talking with the Senate President and with the other folks on the Vaccine Oversight Work Group in the Senate, has been holding these weekly hearings on vaccinations. We've learned things in that process. We've learned things from you and our other colleagues that aren't in the bill that need some fixes. So with that, let me just stop and ask the committee to work with us to get this in a shape that can really help our people. Thank you, Madam Chair.
Thank you. Are there any questions of the sponsor? Well, let me just ask one. Could you give us just a 1 minute summation of what the bill will do?
It requires plans in each of these areas, number one. It then matches resources to plans. It clarifies the role of the local health departments vis-a-vis the state health department. It clarifies who needs to do testing, how much they need to do testing. All of that has been very catch as catch can over the last year. There's a good bit of evidence internationally as well as nationally of the scale of testing and tracing that we're going to need to do easily for the next 2 years, even with vaccines. And we've had no state goals on that. I mean, testing is a good example. Is the state, to their credit, tried to do as much testing as they could get tests for. Well, now tests are widely available. And now we hear and we see that the data that actually the number of tests being done has been going down because we don't have a policy on testing. And so people are saying, oh, I'm going to get my vaccine. I don't need to get tested. Well, as we all here in the Senate know, as we saw yesterday with some of our colleagues, we all need to be tested, and we need to be tested regularly. And it's important. And it's not just important for senators. It's important for all of our constituents in various ways. It's different on college campuses. It's different in employment situations. It's different. But the scale of testing that we need in the state will be significant for the next year. And this basically says, come up with a plan on how we're going to do it. On the testing side, tracing follows from testing. Once people test positive, it's exactly what we went through the Senate in the last 24 hours. Once you do the testing, somebody goes up positive, you got to do tracing. Again, the tracing has not been up to international standards in the state by far. And then on vaccinations, unfortunately, the way this is rolled out is the federal government was not clear under the last administration, frankly, about how many vaccines we were going to get every week. The Biden administration has now made that clear, so at least there's week-to-week predictability. But the reality is that there's still chaos out there, and so the bill and their various provisions basically says the state and the locals have to get their act together on this and coordinate, so that as we scale up vaccinations, we're doing it in a way that is efficient.
So does your bill recommend methodologies for getting the act together, or is it more a work group bill that they?
No, it has very specific targets, and it has very specific mechanics. And that's why I don't want to overstay my welcome here. We can get weedy very quickly on this, and I'm happy to do that. Work with the committee on that.
Okay.
But it's come out of a process of working with the whole variety of stakeholders. And some of the witnesses have some tweaks to it, which is fine. I think we can get this together in a way that will work.
Thank you. Are there other questions of the sponsor? Okay, then we'll go to the major proponent, Joseph Dimattos of Health Facilities Association of Maryland, HFAM. And
Madam Chair, thank you so much for this opportunity to testify in support of Senate Bill 741. It's a very important piece of legislation. I am Joe Dimattos, the president and CEO of the Health Facilities Association of Maryland. It's so good to see all of your faces on this Zoom. I look forward to a time when we can be together again in person. I really want to just hit some high points, a set of high points. Hopefully you have my written testimony and can look at that and ask any questions. I'm going to focus on testing. Many of the lessons around testing are outstanding examples with regard to vaccine going forward. So if you have questions about testing, vaccines, blind spots, please ask me those questions. So let me share those points real quick. We all know now, and we knew probably in March of last year, that COVID-19 disproportionately attacked diverse communities, people with pre-existing conditions, and older Marylanders. Those are folks that just happen to live and work in skilled nursing and rehab centers. And those happen to be, again, friends and family that live throughout our state. Now, this time last year, if you wanted to take a COVID test, you could probably take there were probably a couple of dozen tests available. You would have to get those tests to the Maryland State Lab, and they were assigned through the CDC. It wasn't until March that we had commercial and hospital capacity for testing. And in March, the nursing homes started testing, working with hospital partners in advance of government orders to do testing, because they found that there were these major outbreaks and hotspots of asymptomatic people. And so we had a really big lesson in March that COVID is largely spread asymptomatically, which makes testing essential. So we asked the state for testing in March and April. The state started testing in our sector April through August and provided that testing logistically free of charge to nursing homes. But let's talk about the first blind spot. Neither in Maryland or in the federal government did we focus enough testing on diverse communities, communities at large, and small operators. And one of the important provisions of this piece of legislation is state coordination on that front. Another point, when we shifted from state testing from October 14th, they're doing August 14th, they're doing state testing. August 15th, you've got a contract as a nursing home to do that testing. That was the requirement. But the plans across jurisdictions required by county jurisdictions in terms of deadlines and scope of those plans varied tremendously. Baltimore County took a more reasoned approach. Let's work together. Let's figure this out. Let's figure out what the plan is now that the state's not testing. Other counties said, we want a plan tomorrow. What we really needed was for the state and the federal government to play a more directive coordinating role in that. And again, we still weren't testing adequately in Prince George's County, Baltimore County, Baltimore City, throughout the state, where we know that there are pockets of diverse communities and small operators that needed testing. Another thing that happened when we ramped up testing was that there were delays in getting test results to healthcare practitioners like nursing homes. And so while on the one hand, we were hyping up all this testing and people were getting tested, it slowed down our labs, contrary to other sort of popular belief, not just in Maryland, but regionally. And what that meant was we were testing, but we weren't getting the results back fast enough so that they would be clinically actionable, sometimes waiting more than 3 days or 4 days to get the test results back. I will make a couple of other points that I think are important. Since August, the state of Maryland has distributed 1.3 million point of care test units, and those have been very helpful for the sector. So the state provided PCR testing from April to August. They stopped in August. We as an industry started doing that as of August 15th. It wasn't an easy transition in terms of being able to contract for those services. And then we've had the point of care testing now to augment the PCR testing, right? And one point about the cost, because it's sometimes difficult even for me to understand this in the pandemic. The insurance industry is providing this, which is outstanding. And where's Matt? And I appreciate Matt for that. He's on the call. And these are covered benefits. But there's something that you need to understand about large employers, including those of us in the healthcare setting. And maybe Senator Augustine can remember this when he was in the healthcare sector. Large healthcare organizations buy insurance for their employees, and they self-insure and underwrite that insurance. So ultimately, while testing is covered under insurance, and insurance companies are also underwriting some of that, all true, except if I'm a large skilled nurse in a rehab center, or to Dana's talk, home health care or adult day or any setting, I'm paying for testing. Ultimately, I as the employer am paying for that. And that's between $20,000 and $75,000 a week, depending on what week. So again, I said I was going to focus on testing, but I have a number of answers related to vaccine that you can ask me about relative to testing. I'll share this one last stat with you. The federal vaccination program for nursing homes is coming to an end, like right now. We've done 3 clinics in the nursing homes. We have vaccinated between CVS and Walgreens 90,000 Marylanders who live, receive care, or work in nursing homes. We're kind of in the middle of that with assisted living, but 2 things. We need a plan going forward, and we need a better plan for reaching into the community on vaccine and testing. And with that, I'll await any questions.
Okay, let me just start while colleagues are thinking of their questions, or they might have thought more than I already. I'm not clear so far exactly what this bill is intended to do. What would be the parameters of an adequate regime of testing? And then what percentage of spending ought to go for testing as opposed to for vaccinations? And wouldn't it make more sense to vaccinate more people so you don't have to constantly test, especially since the tests aren't all that accurate, and some more so than others. What should be the official responses of the state and of the localities to the test results that you get from week to week or day to day? And what, let me ask that much. I'm trying.
No, those are, Madam Chair, those are really on point questions. I appreciate that. I think if I had to say the elevator pitch in 5 seconds of what the bill is about and then why it's important, the 5-second pitch is that this bill not only establishes dollars, which quite frankly is important, but from a public policy, like let's keep people alive perspective, for me, more important is that it directs a highly integrated state planned approach. Now, let me just say that the state of Maryland has done better on planning than did the federal government. I mean, just clearly. I've been living and breathing this stuff for more than a year. And, we still have a disconnect between federal agencies. I'll just give you one quick example of where hand sanitizer has to be in a healthcare setting. Like where it physically has to be is still a point of dispute between CMS and the CDC, right? So the federal government has been really poorly organized. That's out of our control. The state government's done a better job on that. But even with the better job on that, we need to do better on coordinating testing in the community. We know from studies done at Brown University, Harvard University, and University of Chicago that people typically catch the virus in the community and then take it into work, whether that's a school, a nursing home, a hospital, whatever. We have not targeted and coordinated our testing sufficient enough to be ahead of that. We've done better than some states, but we can do better. And we've not coordinated that as well as we could with the municipalities, And testing is an example of that. When we shifted from nursing homes testing and the state testing mid-August, as I said, we all knew what the federal orders were and we all knew what the state orders were.
Well, you guys are being very philosophical. I want to know the nuts and bolts of what this bill would do. That's what people are going to want to know on the floor of the Senate.
Yeah, it'll bottom line.
And let me ask you, will we get more bang for our buck by increasing the vaccinations to cover the people who are willing to be vaccinated, as opposed to going on every few days, testing the same people with a fairly high group of false, either negatives or positives, and the constant testing?
Let me give you the bottom line on that. If right now, until late March, we're going to be short of vaccine in this country. We should get more vaccine late March, early April, but between now and late March, early April, we're not going to have enough to go around in the country, including here in Maryland. So if I have 60% of what I need on vaccine, and I know that one specific zip code in Baltimore City or Baltimore County or Prince George's County has a higher testing positivity rate because I'm doing testing and I don't have 100% of what I need. I want to be able to have the state to say, we need more vaccination in that zip code because we're on the verge of having a community hotspot. So that's the connection. That's the bang for the buck.
Okay, well that's helpful.
Madam Chair.
Have other questions of this witness before we move on? Senator Biden.
Great question.
Madam Chair, yep, thank you very much. There seems to be mixed messages about who will pay for testing. So, Mr. Dimattos, what's the current rule now from commercial insurers. If you go in, let's say you have a sore throat, no symptoms. You go in and for whatever reason decide that you want to have a COVID test because you've been exposed to someone. Are insurance companies paying for that now?
Yes, that's diagnostic testing, and in most cases, they're paying for that. So that's the short answer: is diagnostic testing is paid for. There have been some denials of payment in some very specific managed care plans, but those have been outliers. The issue, even on diagnostic testing for self-insurers who underwrite their insurance, is ultimately the employer is paying that. But yes, diagnostic testing is largely covered right now.
So if I was, say, a grocery store clerk and I'm exposed to the public all day, every day, and I just want to be tested once a week just to be sure that I
That might be
haven't been
a great
exposed.
area for Matt to answer, a lawyer, insurance lawyer. But I will tell you that if I'm an employee and I go to my doctor, all I have to tell my doctor for it to be diagnostic is that I believe I have been exposed. And it becomes not a surveillance test, but a diagnostic test. And I think if my advice to consumers would be, if you really think you've been exposed, then go and get tested and say, I think I've been exposed, and handle it in that way.
Is testing all that easy to get an appointment for nowadays? Would you be a week later when it might not matter getting to somebody, even if you were trying?
Yeah, that's still a problem. I mean, people say it's not a problem, but it's still a problem. Partially because much of the travel in our country, even domestically to some states, requires it's precisely that you get the test results within 72 hours of getting on the airplane. So people are planning that, and it's actually making it harder to get actionable results for the consumer. Generally, on the healthcare side, we're doing better with the Diamond Labs of the world and all the other labs.
Okay. So since the bill sponsor said he wanted to use this to help build the system that would make sense for Maryland, we suggest, or any of you can think of it, that we ought to come up with what the protocols are for testing, which is self-imposed in a way on the part of a member of the public who thinks they might have been exposed, or they are an essential worker, so they meet a lot of people and have to have a lot of contact with the public. Just think about that as the various people talk. We've got so many bills to do in voting. I'm going to shut up and go to the next witness, but we need to understand really what you're asking for. Okay, let's go to Nicole Stallings from the Maryland Hospital Association.
Great. Thank you, Madam Chair, members of the committee. And for the record, Nicole Stallings on behalf of the Maryland Hospital Association here in support of Senate Bill 741. I also want to thank Senator Rosapepe for the countless meetings that we've had over the interim and his attention to these important issues. As the committee likely knows, next week will mark the 1-year anniversary of when our hospitals first started seeing COVID patients. And since that time, we have treated over 34,000 of your constituents, your neighbors, your friends, and your family. And yet a year later, our healthcare infrastructure still continues to be significantly strained. Our experience shows that the challenges posed by COVID will continue to evolve. In many ways, we see different challenges with each surge. And so that's going to require the state to have a plan that continually assesses and adjusts to make sure that we're suiting the unique challenges and circumstances and needs of all communities, and in particular, those that Mr. Dimattos just referenced. And so we can't take our eye off of the ball. To your question, Chair Kelly, we must continue to closely monitor signs of spread, and that means testing and tracing. Without doing so, we only notice problems when individuals show up in our emergency rooms. And by then it's too late to potentially prevent that community spread, which will bring another wave of chronically ill patients into a strained healthcare system. And every part of our healthcare system right now is strained. In the beginning, we were strained by lack of resources. PPE, certainly testing, and we need to ensure that the state has a plan so that those challenges do not reemerge. And then one challenge that has persisted across all of the acute care surges that we've experienced is a lack of adequate healthcare workforce. Staffing by far was the top challenge that our hospitals have raised throughout this response. We support any effort to strengthen our healthcare workforce and are especially supportive of the provisions that create the public health job corps, one that is sourced from the communities that we need it to serve. When we met with Senator Rosapepe, the word that I used to describe our state's response was a patchwork. And this patchwork of requirements and policies make a difficult job for healthcare providers, for local health departments, even harder. And this legislation recognizes that we can't have a patchwork. We need to get away from these disparate and well-intentioned policies and really have a more uniform approach. The legislation also realizes that we need to invest now in a long-term response plan. And so for these reasons, the Maryland Hospital Association supports the legislation. Thank you.
Okay. Does this particular bill in its current form address ways of increasing the workforce?
It does have provisions, and I'm sure Senator Rosapepe wants to speak to this. This is one of the things that we talked at length about around making sure that we are really leveraging our community health workers and others to create that job corps. And Senator Rosapepe, I'm not sure if you want to add anything there.
Well, you can't have a man right now. He had his chance. We'll talk some more later with the sponsor, but I just was wondering from your perspective. Okay, are there other questions of this witness, the Maryland Hospital Association? Okay, then we're going to the Maryland City Health Department, Dr. Jarraza.
Good afternoon. Thank you, Chair Kelly, Vice Chair Feldman, and members of this esteemed committee. My name is Dr. Latisha Jarraza, and I'm the Health Commissioner for Baltimore City. I'm here today on behalf of our Mayor, Brandon Scott, in support of Senate Bill 741. The COVID-19 pandemic, as this group knows, has ravaged Baltimore City's communities, and it has taken an unprecedented degree of coordination to aid in our city's response. And we know that more must be done in terms of both planning and investment. For some context, much of our response here in the city has been made possible by leveraging local, private, and community partnerships. Our approach to testing has focused on working alongside community partners to provide access to residents who have the highest need and are most vulnerable to disease. The city made a concerted effort to begin its mobile testing starting in April of 2020 in zip codes with the highest positivity and lowest testing rates. Our efforts, however, were made considerably harder by not knowing when federal or state partners would be delivering testing kits or PPE, or how much of said items might be delivered. With respect to contact tracing, the city spearheaded the Baltimore Healthcare Program alongside many external partners, with most local to Baltimore City. This program was tasked with hiring over 200 contact tracers and community health workers to assist with our outbreak investigation and provide outreach and education to the residents we serve. Likewise, our vaccination efforts have been informed by a flu vaccine strategy that we launched in August 2020 alongside partners from hospitals and pharmacies to our senior housing sites. These sites have been selected based on vaccination rates and density of older adults. Unfortunately, vaccinations have lagged significantly behind demand, which has been spurred by a phased eligibility schedule developed with little consideration for partner capacity and supply. The common threads among our COVID-19 efforts have been the need to do more with less and to do so with minimal assistance from state and federal authorities. Public health is often the first line of defense against the threat of a pandemic. Unfortunately, the COVID-19 pandemic highlighted not just the lapses in public health planning and coordination between local, state, and federal stakeholders, but also how overburdened and under-resourced public health has been for years. Senate Bill 741 will bolster our ability to effectively respond to COVID-19 as a city. Our capacity to increase contact tracing efforts, testing, and vaccination hinges upon the bill's estimated $40 million in local government grants allowing us the flexibility to invest in supports like information technology. An investment in our IT infrastructure and data-driven approaches is necessary to address disease prevention, surveillance, and preparedness, all of which have been crucial to the COVID-19 response. Again, to protect our residents, more must be done. We need more coordination and we need more investment. For this reason, Baltimore City requests a favorable report for Senate Bill 741.
Okay. Doctor, you gave us a great summary of what you've been dealing with and so on. What in the bill strikes you as being particularly important for meeting some of those needs that you're wrestling with?
Yeah, I think some of it's been covered, but really it's the ability to do some long-term planning around contact tracing as well as testing and vaccination. Right now, again, early on in the pandemic, there was much we didn't know. So we were planning on the fly. When were we going to get adequate testing supplies? When were we going to be able to do mass and surveillance testing? Now that we have a better handle on what is actually accessible, how do we better coordinate that efforts? I think one of my colleagues spoke to the efforts being done at nursing facilities, but we're going to need to do testing for a long time. Even with more vaccinations, testing will actually become probably more critical so that we can identify those people that aren't showing symptoms, but are positive.
What page or what section of this bill comes up with a path you'd like to follow with regard to that particular variable?
So I don't have the bill in front of me. If you give me a moment, I can pull it up. But again, I think it's more just the overall ability to coordinate better.
It sounds like a nice philosophical bill so far. I confess I haven't read it all, but I'm not hearing how we use it to get from point A, which we all agree is inadequate, to the state of adequacy that you wanted on which variables. Okay, so anybody who, when you're talking, can help us. And if you don't get a chance, because we aren't giving you that much time today, we just don't have it, but you want to send something back, you can send us an email or whatever, and let us hear what you think we can do using this vehicle to help you get where you want to go. Okay, any other questions of this witness? Senator Reedy.
I have a question. I'm not sure, maybe this witness maybe isn't the one necessary to ask. Latisha, I appreciate your testimony from the Baltimore City perspective. I guess maybe a more general question is I've been reading through the bill and listening to the chair's comments. Certainly laying out plans makes a lot of sense. There's a lot that makes sense to have long-term planning. But I wonder if in another year, we're going to want to have an abject thing in the law that says we want to have 100,000 tests being conducted. I mean, there's some specific numbers in the bill. This may not be as big of an issue in another year, but, we might decide, hey, I mean, we're treating this, but we're treating this right now. We're in this pandemic, but we're hopefully coming out of it pretty soon as far as the high levels of where we're at. Not that we won't need to continue to be somewhat careful, but some years the flu may be a much worse problem now that we have a vaccine or other types of diseases. And so we're going to set up a whole structure for this. I guess I'm just asking a philosophical question. Is it wise to set this up this far in advance? I mean, I don't know if anybody that's testified so far could comment on that.
Yeah, I mean, I can speak very generally, but certainly others can chime in. So again, not to be too broad, but generally speaking, public health has been underfunded and under-resourced. So that when this pandemic came, when we were hit with COVID, this new virus, we were scrambling to ensure that we had adequate staffing to be able to support an appropriate response. So when I think about this bill, I think it helps to lay the foundation for the much needed infrastructure moving forward in the event that something like this happens again. But yeah, it is pretty hyper focused on COVID for sure. Right.
Which again, I get. I mean, but do you think it, and maybe this is something we can talk about more offline with the sponsor and others, but I mean, I'd want it to be flexible because we don't want to have, there may be something different that, that needs to be, we may need to pivot and use money for something else that comes up or in the health space so I mean, I'm just throwing that out there as I read through the bill and the discussion.
Sure.
Madam Chair, may I address Senator Reedy's issue?
Go ahead.
I think the point that the doctor made is critical and you may agree or disagree with it, but I strongly agree with it. is this is not going away fast. We thought it was going away fast in March, in April, in May, in June, in July, in August, and September. This weekend, because they do surveillance testing at the University of Maryland College Park, they identified an outbreak and they ordered all the kids to stay in their rooms this week because of surveillance testing. We're going to have that problem way beyond this year. That is the experience with other pandemics around the world over the centuries. And the public health experts say it is not going to be over. It's going to be better. But the idea that we get vaccinated, we're one and done, is just not consistent with the experience with pandemics. And the regular old flu is a good example. The reason we have flu every year is because that particular virus doesn't go away. It mutates and comes back every year in a different way. This one obviously is much more dangerous, but it is going to be with us for quite a while. The bill is structured to deal with both issues. It's designed to deal with the short-term and medium-term issue, the rest of 21 and the rest of 22, which is very focused on COVID. But it also includes a work group to plan for exactly what the doctor talked about, which is the public health infrastructure going forward. So I realize it's a very big bill with a lot of moving parts, and I apologize that I didn't make it clear in the opening, the chairman's question about where's the meat. There's a lot of meat in this bill, a lot of moving parts, and really look forward to answering all the committee's questions at your convenience.
Okay, thank you. Are there other questions of the last witness? Okay, we're going to Kaufman. Lifespan.
Thank you very much. For the record, my name is Dana Kaufman. I'm here today actually on behalf of Lifespan and the Maryland National Capital Home Care Association. And I want to address two provisions in the bill. Under the testing plan portions of the bill, there is a requirement for nursing homes, assisted livings, and home health agencies to periodically or to test based on a schedule to slow the spread. As you know, nursing homes and assisted livings have been testing basically from the onset of the pandemic. And while the health department did provide assistance for testing, that assistance was only up until August 15th, and then some rapid tests were done or provided after that. But the nursing homes and assisted livings have pretty much been on their own for the cost of testing up from that point on to now, and they continue to have to test, and they're actually testing twice a week per either a PCR test or a point of care test. And you can imagine that after so many months of this is financially very difficult for them to continue. Now, the bill does have appropriations for funding. However, those appropriations are not mandatory. They are unfortunately the intent of the General Assembly, and why we appreciate that intent, again, the appropriations are not mandatory. It's my understanding from the Department of Legislative Services that you cannot mandate funding until fiscal 2023 in a bill at this point. I learned yesterday that from the federal funding, Maryland is getting a substantial amount, but we need to make sure that monies do flow for these purposes for a testing plan, because I will say that with the increase in the vaccine, the testing is mostly going to be hopefully surveillance testing and not diagnostic testing, especially as it pertains to the residents, where we had a very high level of residents being vaccinated. On the home health agencies, we do have a concern about a testing plan. This would be, CMS has not required a testing plan for home health agencies. They do require screening. However, home health agencies, as you know, are not a congregate setting. So logistically, it makes it much more difficult to do a testing strategy for both their staff, but especially their patients. And again, unlike the nursing homes, assisted living, or even the colleges, you are providing care in somebody's home. So while we understand the impetus of wanting to have somebody testing, you can't ignore the logistical issues that go around trying to have a home health aide test a patient in their home. And again, there are issues with trying to even test staff when they're not in a central location. So those are our concerns with regard to the testing of home health agencies. But again, moving forward, we do need to make sure that monies, if we are to implement a long-term testing strategy, are appropriated and covered by reimbursement policies or just on their own. So thank you very much.
Thank you. Are there any questions? Okay, we're going now to some unfavorables. Vince McAfee.
He's not in the meeting.
Okay, he's not here. All right, Matthew Celentano.
Good afternoon, Madam Chairman, members of the Senate Finance Committee. Thank you very much for having me today on behalf of the League of Life and Health Insurers and AHIP, America's Health Insurance Plans, opposed to Senate Bill 741. First and foremost, just to be clear, carriers are paying for testing now with zero cost share. And that is not going to stop for a very long time, no chance before the end of the state of emergency. And for diagnostic testing, I don't think that's ever going to happen. But we're here today with the concern of the testing portion of the legislation, which basically becomes surveillance testing paid for by carriers. There's a reason that carriers pay for diagnostic testing, which is to determine illness when there is a reasonable suspicion of illness, which includes known or suspected exposure. This bill takes all of the reasonable suspicion out of the calculus and requires carriers to pay for testing regardless of exposure to symptoms. It takes the concept of public health surveillance and tries to make the carriers the administrators. One of our concerns is that since the Maryland General Assembly and the Maryland Insurance Administration only has authority over approximately 17% of the insured lives in Maryland, it won't get the desired intent of the way it's written. It has to be a state-led approach. The bill will also have unintended result of driving healthcare costs in a negative direction, which would kind of undo all the work this committee has done over the past couple of years to reduce healthcare premiums, especially with the proliferation of at-home tests that could be expensive. Carriers under this bill will be responsible for paying for those tests. We're also all aware of Marylanders using testing as a way to circumvent public health advice. Lots of people were warned to stay home over the holidays, but they didn't listen. They justified their irresponsible behavior by getting tested before departure and upon return. This testing is not diagnostic. In addition, the use of this kind of testing approach didn't starve off the holiday surge of infections, but we're still just starting to come down the curve from. Carriers would now be financially responsible for questionable behavior. We're also concerned that we are not the business of paying for business decisions. An example might be a hardware store in Moncton, Maryland, that has a sign out front that says, "We test our employees once a week," to create consumer confidence to enter the store. Well, we don't want to discount this approach. That's a business decision of the company. Why should an insurance carrier be responsible for that business's decision? Today, businesses who are making that choice cover the testing as a part of their business expenses. And this bill would directly shift those costs into the insurance pool, which will have negative premium impact. Lastly, there's another COVID-19 relief package working its way through Congress right now that includes a lot of money for testing, tracing, vaccination through the public health system and addressing all Marylanders that might alleviate the need for the approach on testing, mandating testing by carriers in this bill. We know there's more money coming. We should use that to have a statewide strategy. So for those reasons, we urge an unfavorable report on Senate Bill 741. Thank you.
Matthew, would you say that if we were to take this approach and not listen to what the carriers are saying, everybody's premiums are going to go up no matter what, if you've got any kind of insurance in Maryland, health insurance in Maryland, because they would have to raise them in order to do all of this surveillance testing that has nothing to do with the diagnosis of a particular person for whom they have in their portfolio of covered lives, would you say?
Chairman Kelly, that's exactly our concern.
Okay, are there other questions? Senator Bidle.
Mute. Thank you. And Matt, thank you for your testimony. So are right now, are commercial payers pretty much paying for all the testing and they want to stop, or are they not paying for testing now?
No, the answer is no, we're not stopping. Yes, we're paying for it, and there's no timeline to stop. Right now, it's basically no questions asked as it is. The doctor orders the test, they send in a CPT code, and the carriers are paying for it. That's not going to stop. This bill would extend it past diagnostic to being the surveillance tester. That's the role of Maryland. That's not the role of the insurance company.
So you said the doctor orders the test. So that means I can't just go into my clinic and say, I think I've been exposed and I'd like to be tested.
You can do that. You can do that too, and the carriers are paying for it. No questions asked. I mean, you can ask the MIA. There has not been any complaints on this front that I'm aware of to the MIA since the pandemic started. The carriers have stepped up to the program and made sure there is no cost share for testing, for treatment, for care in the hospital, no cost share for anything on COVID-related illness.
But going forward, there will be?
I mean, at some point, there's no way before the end of the public health emergency, no chance whatsoever.
Okay.
But I can't say for 3 or 4 years from now, but I guarantee that COVID-19 is going to be a covered service as a diagnostic test as a part of your insurance.
Thank you.
Okay. So in other words, the same person can't just be reckless and keep running around with no mask or fraternizing or riding in the center seat on the airplanes and then coming back and expecting the carrier to do a surveillance test for them every 2 or 3 weeks.
Well, that's what we're worried about, Senator Kelly, is that folks are just going to use the testing strategy of I'll be okay if I get tested now and later, and then use reckless behavior that puts themselves at risk. So it all comes around the circle, and that's going to drive costs. That's what we're concerned about. If you have symptoms or you've been exposed and you tell your doctor that, we're going to give you a test. That's appropriate because we want to make sure you stay healthy and we find out about it to make sure you don't get sicker later. It's a whole circle of insurance.
But if you were to see a pattern, the same person every 2 or 3 weeks needs to come back and have the insurer pay for another test.
Well, under this bill, Senator Kelly, that would be okay.
Well, that's what I'm saying. But if that were to happen, everybody's premiums have to go up.
That's correct. That is correct.
Any other questions? Okay, I think Matt was the last witness on this. Okay, very interesting bill. It's going to require some work, but these are important questions and we got to do our job.
Thank you, Madam Chair.
Senator Edwards is not available. We're going to go to Senator Augustine.
All right, we're going to Senator Augustine next. Senate Bill 638. And Senator, you have all the time you need, and Lori Dole, the main witness, who will have the 5 minutes. Okay.
Thank you, Chair Kelly, Vice Chair Feldman, and members of the committee. Senator Malcolm Augustine, speaking on behalf of Senate Bill 638. Colleague, Senate Bill 638 is an emergency bill that requires the Maryland Insurance Commissioner to enforce a provision of the law 15-1005, which is in the insurance article, which applies to the delivery of specialty mental health services established for Medicaid managed care organizations, enrollees, and administered by ASOs, Administrative Service Organizations. As this committee is aware, Optum took over the Administrative Service Organization for the Public Behavioral Health System on January 1st of 2020. The main functions of the ASO are to authorize services and pay claims. It became quickly evident that Optum's system was not functional in these 2 critical areas, to the point that MDH had to authorize advances or estimated payments to providers. Almost 8 months later, in August of 2020, the estimated payments ended and Optum's system once again to begin to pay claims. Unfortunately, many of the bugs that plagued Optum's system earlier continued after the go-live period. We heard about many of these issues in a briefing held before our committee November 19th of last year. Now, these glitches in Optum's system have resulted in late payments and growing provider accounts receivables well over 30 days, a violation of existing statute. This is true of large community providers, hospital systems, as well as small niche providers. In addition, despite Optum's repeated promises and deadlines, providers are still not receiving reports within 30 days that let them know if claims submitted have been accepted or rejected. And if rejected, why? This lack of reporting hampers providers' ability to perform revenue cycle management and is also a violation of the current statute. Now, just to kind of get really into the statute itself, 15-103 of the Health General states that 15-1005 of the insurance article applies to the delivery system for specialty mental health services administered by the ASO. And as I previously stated, it indicates that within those 30 days, they must mail or otherwise transmit payment, send a notice of receipt and status of the claim specifying the ASO refuses the reimbursement, and then allows them to determine if all or part of the claim will be reimbursed. And then the state claim is not clean, the specific additional information necessary for the claim to be considered a clean claim. This subsection includes a provision of interest, penalties, if the ASO violates these requirements, and establishes the fines and penalties for arbitrary and capricious violations, as well as penalties for violators whose frequency rises to the level of a business practice. According to a letter that we received from the MIA does not have statutory authority to enforce compliance by the ASO with these prompt pay provisions. That authority currently is within the Maryland Department of Health. Now, Senate Bill 638 gives MIA clear statutory authority to oversee Optum's compliance with 15-1005. We believe that the MIA is best positioned to perform this oversight function. The provider impact by Optum system failures are safety net providers in our communities. They continue to serve those in need in good faith and have also worked with Optum and MDH to try to fix the system's shortcomings. Many are historic providers who have operated under 3 prior ASOs and have experienced nothing to this magnitude. In fact, this issue of prompt payment and adequate claims reports has never even been raised in the almost 25-year history of ASOs, because prior ASOs paid within 14 days of claim submission and routinely provided quick feedback on acceptance or rejection of claims. Our safety net providers simply cannot continue to be underpaid and to divert scarce human resources to clean up behind Optum. I also, just to get some clarification, asked for advice from the Assistant Attorney General of the Office of Counsel to the General Assembly, who came back and shared with me that it was their belief that MIA's position, which they had also shared, that they do not have under current law jurisdiction to enforce prompt payment standards as applied to MDH's specialty mental health service delivery system, and that's consistent with the statute. But that's why we put this legislation in, to rectify that situation. So passage of Senate Bill 638 is an action this committee and the General Assembly can take to hold Optum accountable to our providers and individuals they serve. I urge a favorable report on Senate Bill 638.
Good testimony. Okay, a big problem. Are there questions? Okay, then we're going to Lori Doyle. You have the 5 minutes, Lori.
Thank you, Madam Chair. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. First off, I want to thank this committee for keeping this issue front and center from the time that Optum first came in and their dysfunction started January 1 through the briefing last November, and now with this hearing. In fact, a lot of you have individually stepped up and tried to help our providers by contacting the department when they weren't getting paid. So thank you all for keeping this in your sights. Senator Augustine did a great job of outlining the really sad history of this vendor. And unfortunately, since the time that they went live again after the period of estimated payments, the problems persist. A most recent survey of our members shows outstanding accounts receivable at about the $60 million range. That's a lot of money. And that does not include, by the way, solo practitioners who may just decide that they can't see Medicaid patients anymore because the hassle of trying to get paid is just too great. So in desperation, we went to statute to find out, do we have any redress at all? And we found out, yes, we do. That Health General 15-103 does say that the ASO is subject to the insurance article 15-1005, which does exactly what the senator says. It says that the ASO within 30 days either has to pay the claim, dispute the reimbursement amount, or tell the provider the claim is not clean and what they can do to make it so. And it provides for interest, penalties, and fines. These things are still not happening. So we went to the MIA and said, can you help us with this? They were very helpful, I have to say. They asked us to submit some overdue claims to them, which we did. But they also said at the time that they weren't sure they had jurisdiction to enforce the provisions of this article. And they then sent us a letter eventually from in consultation with the AG, who said, you know, right now the enforcement sits with MDH. They got back to us and said that they forwarded these late claims that we had sent to them to MDH. That was the middle of January. We've heard nothing back. There is no process with MDH to make a claim about these provisions. And I will just say that, you know, in the fiscal note, the department says, you know, we're only going to look at claims after August 3rd. That's fine with us. That's exactly what we submitted. We're claims after August 3rd. It also is interesting that the insurance article basically states that the person who submitted the initial claim should not have to go back and submit a claim for interest. That ought to be automatic. So none of these things are happening. I would say that probably the most frustrating part of all this is that what we hear from Optum and MDH is that the system is going fine. They're paying the claims. Any problems are as a result of provider error. And I can only say that first off, Optum's numbers are wrong. They keep processing and reprocessing the same claims over and over and over again. So a provider will submit a claim, it gets denied. It's then reprocessed, it gets paid at the wrong rate. It's then reprocessed and paid at a different rate. And this can go on and on and on for one claim. I would also say that our providers are historic providers. We've been doing this for a long time. We did not suddenly forget how to bill a claim or how to get an authorization. We've been doing this long before Optum came to town. And also that most of us use EHRs, electronic health records, and those are programmed to stop mistakes before they even go out the door. So there's a lot of quality controls already happening. So I don't buy the argument that it's just provider error. And thirdly, if Optum is truly paying and doing these things that they say they are doing, they have nothing to fear by this bill. They're already compliant. So I'll just close by again thanking you. We have to get some resolution here. If MIA can't enforce and MDH won't enforce, it basically nullifies the statute that you all passed to protect providers from this very circumstance. So again, thank you, and I hope you will pass this bill with a favorable report.
Bill sounds very, very good to me. Senator Augustine, are you accepting co-sponsors?
Of course.
I think a lot of members of this committee might want to sign on. I mean, we do have a mess, and
Yes,
we all know it. Okay, let's go next to Scott Becker.
Thank you and good afternoon, Madam Chair and members of the committee. My name is Scott Becker and I'm the Chief Financial Officer of Catholic Charities of Baltimore. Catholic Charities provides care and services to Marylanders throughout Central and Western Maryland. Among our many programs, we provide outpatient clinic-based behavioral health services in Anne Arundel, Baltimore, Frederick, Harford, and Allegheny counties, as well as Baltimore City. In addition to clinic-based services, our therapists provide school-based care to children and youth in more than 120 public schools. In total, we engage in 11,000 billable behavioral health encounters each month, all of which are processed through Optum. Within my finance team, I have a small group of long-tenured expert billings and claims management professionals who have worked through 3 different ASO transitions. I can confidently state that this skilled team has never seen anything like what we have experienced in the past 13 months. Since the transition to Optum began in January of 2020 through August, Optum was unable to process individual claims for these critical services. Instead, we received estimated payments arbitrarily based on prior year activity. Since August, claims-based payments from Optum have been equally unreconcilable to our billing records, again at a pace of 11,000 sessions per month. So from January of 2020 till now, a period of more than 13 months and 150,000 client encounters, Catholic Charities has amassed approximately $15 million in unreconcilable payments from Optum. As a result, our books are an unacceptable mess. I have no idea how or by when we will be able to clean up the mess of the past 13 months. I'm extremely troubled by that, and so is our board. What's worse is that with each passing day, this issue only grows larger for Catholic Charities as well as the broader provider community. It's therefore imperative that this ASO be subject to the additional oversight and accountability standards that this bill provides. I thank you for the opportunity to testify, and I urge you to issue a favorable report on Senate Bill 638.
Thank you. Let me ask, I'm seeing this is an emergency bill and will go into effect whenever it gets through the process. Mr. Sponsor, have you checked to see if we can have it become enacted before we leave session?
I haven't, but I can absolutely do that.
Let's see, I mean, because the problem is growing by the day.
It is on a day-by-day basis.
Standing still.
Yeah, I agree.
Yeah. Okay. Okay. All right. Are there other questions of our last witness? Senator Hershey and then Senator Bidle.
Thank you, Madam Chair. Actually, I was going to ask a question of Ms. Doyle, but I liked your offer of co-sponsors even better. So hopefully I know where this bill is going. But I might just make a suggestion based on the comments from Ms. Doyle about how MDH apparently feels like everything is going smoothly, that maybe if we do pass this, we could possibly add some amended language that would require MDH to do a survey of all of those that are using Optum and report back how it really is working. Because I agree with Ms. Doyle, it's not these providers have just not figured out how to way to do it and don't understand the system. There is definitely something wrong with the system. It is not operator friendly. Unfortunately, we'll probably find out at some point in time it was a very bad choice from MDH as far as their procurement process went and who they selected. But I think it's important that we get some information from the actual providers that are using this to find out what the real story is on whether or not this system can be adequately used or not.
Remember, we did hold an interim session on Zoom.
Yeah.
That's right.
And we listened to providers from all over time. The situation was bad and Beacon just wasn't doing the job. You couldn't trust anything they said or did. And remember when they said at one point, well, we'll let them pay out a certain amount and pull back later.
That's right.
Too much or give more if there were too little. I mean, we really have no system right now. This needs to be done almost immediately. Well, it really does.
I agree. Thank you,
By
Madam
the
Chair.
day the situation gets worse, and we're in the middle of a pandemic besides. A lot of people are having mental health issues who never did before, didn't recognize them because of depression and isolation, and things are getting worse. Okay, Jeff Richardson, I think you, oh, that's right, Senator Bidle, then we'll go to you, Jeff.
Thank you, Madam Chair. And this is just a real quick question for the sponsor. I see in Ms. Doyle's testimony multiple letters from MIA where they can't enforce or didn't have the jurisdiction to enforce. Have they responded to you about your bill? I don't see a letter from MIA in addressing your bill.
Yes, I have. I've talked with MIA, continue to talk with MIA. We've talked about the best way to proceed, giving them this authority. So they are aware of it. They have an infrastructure to be able to manage some of these things. There are still some questions about penalties and things like that, but they are aware of it. I have been talking with them about it, and they have, like Ms. Doyle has said, they have been responsive in this process.
I think she does raise a good question. It might be good if we could get a letter from them saying what timeline they could begin to take up the mantle by, and what things they would need in the interim to be ready to go.
Senator, thank you for this very good bill.
Okay. But this is a good bill, most needed. All right, Jeff Richardson.
Well, Senator Kelly, I couldn't have given my testimony any better than you all already have. You've done a great job articulating the issues. My role here is I'm Vice President and Chief Operating Officer for Sheppard Pratt. Sheppard Pratt serves over 70,000 people across the state of Maryland, and we are the largest behavioral health provider in the state. And I can tell you all the things you just heard are the same for us. This is the third ASO transition I personally have been involved with, and this has by far been the worst. I don't even think we can call it a transition anymore because we're into this over a year. So transition is more like a train wreck. The other thing that I think is really important that you touched on, which is along with the pandemic, we are in a behavioral health epidemic. The demand for all of our services, all of our members across the state, I can tell you at Sheppard Pratt, the demand has exploded. This is a distraction. It's a waste of energy and time and focus where our team should be focused on delivering care and services. It's that plain and simple. And so to give you a few data points around our particular impact, we've continued to have authorization problems through all of this. And I do remember testifying with you all earlier this year about this, is that we have no explanation with some inconsistency, processing issues, overpayments, underpayments, and still receiving patient claims for even other providers that we haven't even provided. So that shows you the integrity of the data or the lack thereof. The other point that I think Scott mentioned too is, we also have audit concerns. People audit us and look at our books to see how reliable we are in terms of being able to meet our obligations. It's hard for us to validate what's happening when these systems are falling apart. It gives others very little confidence that the system is moving in the right direction. And one of our organizations had 23% of its claims denied, and an additional 12% were disallowed, resulting in millions of dollars of underpayment. In fact, based on the data that we have from pre-Optum and data Optum provided us, they're denying and disallowing about $12 million net over what Beacon had approved for the same set of services. And this was twice this number about 3 weeks ago. So that gives you the scope and scale of the dollars we're talking about here. Additionally, we have 30,000 claims that have been submitted with no response at all from the Optum system. And we have 335,000 claims that are in over 30 days. So we're wasting an enormous amount of time due to these administrative efforts to fix repeated problems and failures, creating more uncertainty at a time when demand is exploding. All of us are here because we care about services. All of us have hired very strong billing teams to take care of this and have an enormous success with other payers. This is not a provider billing problem, but it is becoming a public health problem. We are losing, every day we spend time on this, we're losing the focus towards providing these critical services. And I can't overstate that. I'm a social worker. I do this to care for people. We're wasting our time and money, and we're wasting the state's time, money, and resources. And the other really big issue here is that there's no integrity to this data. So it's difficult for us to both financially plan, and I imagine for the state to look at data about truly what the costs of services really are, because this data.
But you've run out of time, but you've made your point.
Okay.
Just suggest, Mr. Sponsor, you and I will go to the head of this place and see what we can do to move this as quickly as possible. And we'll talk to the MIA to be sure when they can be ready to take up. I'd love to see the entire Senate delegation, all parties standing at a bill signing before we leave here, if at all possible, so this could move ahead. I can't think of anything more important.
Yes, ma'am.
Yeah, Senator Benson, you have a question? Because we got a lot of bills and then we got to vote, so we'll be here a long time tonight.
I wanted to just ask
Yeah, go ahead. Go ahead.
Yeah, the question I want to ask is, have we considered doing two things? One is writing a strongly worded letter to whoever was responsible for bringing this incompetent group on board. Have we thought about that? Have we thought about writing a letter? Senator, have we thought about writing?
No, I have
But in
not sent
addition
that
to
to
that,
MDH, but Senator, we're so far down the line with these folks. I mean, I know that a lot of people have reached out over and over and over again. And this is just gotten to a point where that's where the folks have just, we're trying to just, come up with a solution right now. The asking for help and is just going on for, as they mentioned, for the entire last 13 months. So that's why we find ourselves where we are today.
I'm telling you, we need to do something to express our profound and deep displeasure. I know all summer long, as a matter of fact, I have a relative who has a business where she's dealing with the mental health as it pertains to children. And she has had a terrible time this summer trying to get her money. It's just been a heartache and a headache. And I'm certainly willing to, I want my name to be first as one of the co-sponsors. The other thing is, can we, I know that we're talking about of this emergency piece of legislation, but it seems to me that this committee should do something more than that. I'm just, to be honest with you, I'm a tad bit angry about the fact that these groups, Shepherd Pratt has to come before us to talk about. I mean, it is just unbelievable. It's heart-wrenching. So I'm just wondering, is there anything that we can do as a committee to, in addition to this emergency piece of legislation, to show our profound and deep displeasure?
Okay, is that directed, Senator Benson, are you directing that to anybody in particular? The chair?
Yeah, I'm just asking.
Okay.
What do you think, Mr. Vice Chair?
Well, I think that we
should be doing?
I think that we're going to talk with sponsor Senator Augustine. I think he's got some good control of this important topic, and I think you heard the chair. So I think it'll be at the top of our radar screen. So
okay, thank you,
Senator. I think we got a plan. I think we got a good plan on this bill for sure.
Okay, thank you. Thank you.
Okay, I believe that concludes the bill hearing on Senate Bill 638, unless there's something here. And with that, we're going to go to the next tier. We're actually going back to Senator Edwards. So we had skipped over Senator Edwards. He wasn't in the House, but now he is in the House. Senator Edwards on Senate Bill 621. Senator, it's all yours, and you've got unlimited time to present the bill. Senate Bill 621.
Thank you, Mr. Vice Chairman. I'm not going to take a whole lot of time, I can tell you that. This bill basically is requesting, and I see that she's on here and signed up to speak, Garrett County Chamber, Nicole Christian. She's more of an expert than I am. I don't know a whole lot about insurance, but it would, for the purposes of group health insurance, Senate Bill 621 would say that a chamber can be considered an association for healthcare insurance. I'm not sure how these things work, but I belong to certain groups. I can get dental insurance, I can get car insurance, I can get life insurance. I'm not sure about health insurance. I have to go back and look at some of these. So I don't know why. This would be an attempt to allow, you got a lot of small businesses who can't really get it on their own or it costs them an arm and a leg, but they belong to the chamber, and the chamber can be the association. They pay their dues to the association. They could participate in insurance. Very simply, that's my understanding of it. And I asked Cole and her people to get with the bill drafters, put the bill together how they want it. So I don't want to put her on the spot, but I'm going to turn it over to Nicole Christian to speak on it. I saw her there someplace.
Okay, Senator. Before we go to Ms. Christian, any questions for Senator Edwards, the sponsor? Okay, seeing none. Ms. Christian, you've got, you're the designated proponent, lead proponent. You get 5 minutes.
Thank you, Mr. Vice Chairman, and thank you, committee members, for the opportunity to speak with you today. As Senator Edwards said, I'm Nicole Christian. I'm the President and CEO of the Garrett County Chamber of Commerce. I am here on behalf of our 600 members in support of Senate Bill 621. The premise for this is very simple. It would allow for the creation of association health plans in Maryland, and it could potentially save our small businesses thousands of dollars and provide health insurance to thousands of Marylanders, many of whom are uninsured. It basically allows small businesses to pool or group their employees together through a chamber of commerce or a union, and then that group is rated as a large group. It's very similar to the way large businesses with hundreds of employees have better rates because the risk is spread across so many lives versus just the few lives of one small business. We're talking about very rich health insurance plans and having these plans at affordable rates for small businesses the same way it is for large businesses. These are not mandate light or dumbed down plans. Association health plans are not allowed to cherry pick or discriminate based on health or prior conditions. The plans must include all of the benefits mandated by the Affordable Care Act and by the state of Maryland. The U.S. Department of Labor has instituted important safeguards and consumer protections. We want to work with insurance companies that are already here in Maryland, and we fully support oversight by the Commissioner of the Maryland Insurance Administration. I know that they have submitted a letter of interest, and we're going to work with them if there's an amendment needed for the bill. Again, we welcome the oversight of the Commissioner. We're not trying to skirt Maryland laws with these plans or attempt to purchase insurance from out-of-state providers. I know that there has been some concern about fraud because of the past, but we're talking about fully insured plans provided by legitimate insurance carriers such as United Healthcare, Care First, Kaiser Permanente. We would want to try to work with all of these in-state providers. These are quality plans at affordable rates. They're not self-funded plans or MIWAs. There is no evidence currently that the creation of association health plans will create a disparity between healthy and sick businesses participating in the small group market versus participating in association health plans. Because AHPs are prevented from cherry picking and denying coverage for pre-existing conditions, AHPs will have a mix of sick and healthy businesses participating. It doesn't mean that only sick businesses will be left to participate in the small group market. Based on an in-depth discussion I had with Michelle Everly, the executive director of the Maryland Health Benefit Exchange, I feel comfortable saying that AHPs would not be in competition with the small group market, or SHOP as it's known. 12 states have already adopted rules to support association health plans and have seen little or no effect on their small group market. The Morgantown, West Virginia Chamber, which is just across the border from Garrett County, launched their AHP in January of 2019, and they've had great success. The national average is 12 to 15% savings, which can mean the difference between a business offering health insurance to their employees or not. The Garrett County Chamber estimates around 300 businesses in our region would gain access to affordable health insurance under a qualified association health plan. Small businesses have been battered by the pandemic and need all the help they can get. Additionally, at a time when access to affordable health care has never been more important, allowing the creation of association health plans would provide thousands of Marylanders with health insurance. I respectfully request your favorable report on Senate Bill 621, and thank you for the time with you today.
Okay, thank you, Ms. Christian. Any questions for the witness? Okay, seeing none, thank you. We're going to go to Colby Ferguson from Farm Bureau. Colby, you've got 2.5 minutes.
Thank you, Mr. Vice Chair, members of the committee. Colby Ferguson on behalf of Maryland Farm Bureau, and we support this this type of legislation. We're seeing, particularly in the agriculture community, our farmers are, a lot of them are sole proprietors. They're small operations and they fall within a single, most of the time they're individual family coverage, and if they don't have a spouse that works at another location that provides health care, they're in the healthcare coverage program. And when you get into it as an independent, you really have literally one option to pick from. There's not like the rest of us where we can pick from. If you're in a regular business where you have multiple selections, you really have the one healthcare exchange, and it's literally one group, healthcare group. And what we were looking at is, and we love the idea of the Chamber of Commerce bringing this forward. I know this is the multiple years that this bill has been in, and we've actually looked at it ourselves. We have a kind of a healthcare coverage program. We're working with a broker, but we would love to see the opportunity, even as Maryland Farm Bureau, to get into this component and even partner with the Chamber as an opportunity, because where the Chamber's coming in is really going to help those businesses that have that 3 to 50 employee type small businesses. We're really looking to focus on those single proprietors or sole proprietorship ownership, small farmers, to make sure that they can get into more of a group, small group coverage, particularly within like-minded agricultural operations. So we do really like the bill, and we hope that this bill will move forward. I know that this has some conflicts with whether this dilutes the pool by dividing up the businesses, but we do think that their healthcare coverage and healthcare costs is extremely expensive. Talking to some of our farmers, we're talking $19,000 to $20,000 a year just to cover their family, and that's the only option they have. And we're just looking for more options. So with that, we support the bill, Senate Bill 621, and if an amendment could even be put in to allow Maryland Farm Bureau to be added, we would support that. Thank you.
Okay, thanks, Colby, for your testimony. Any questions for Mr. Ferguson? Okay, seeing none, we have one witness signed up unfavorable, a familiar face to the committee, Allison Taylor.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. We are regretfully in opposition to Senate Bill 621 today. We are big supporters of moving towards a system of greater affordability, access, and inclusion for everyone, individuals and small businesses in the state. We just don't think this is quite the right mechanism to do that. And so I'll give a couple of reasons why. So association health plans are not a new concept. They've been around since the 1970s. With the passage of the Affordable Care Act, it did require association health plans to be subject to the law's small group market rules. And a lot of that relates to requiring plans to cover essential health benefits and providing other consumer protections that we think are important. We are concerned about adverse selection here. If certain groups are allowed to band together and move out of the small group market in this way, there's a lot of incentive created for populations that are probably healthier to leave the market, leaving a less healthy pool together to be covered by this. To be covered by the system, it would raise premiums for that group as a whole. I know this committee has worked hard at bringing down premiums in the individual market, and we wouldn't want to see something like this that could potentially raise premiums in the small group market after all the work that's been done. Ms. Christian did raise a point about a concern that the MIA raised about whether this would eliminate their ability to regulate out-of-state plans. We have the same concern specifically. And that's noted in the fiscal note, and I would also note the fiscal note also raises the concern about adverse selection that's on page 2. So we'd be happy to work with the proponents and all other interested parties towards policies that support affordability in the small group market, but we're strongly opposed to this concept here and would not like to see it move forward. Thank you.
Okay, any questions for Ms. Taylor?
Oh, one last thing. I also want to know, we're not the only party in opposition. Care First has also submitted a written opposition to this
Yes,
bill.
I apologize. You're the only one who's signed up to actually testify orally, but we do have extensive other written testimony. So, okay, I don't see any questions from Ms. Taylor. And that being the case, that concludes the bill hearing on Senate Bill 621. Madam Chair, I see you're back in your seat. Let me turn it back over to you for the next bill.
Okay, thank you. All right, Senator Hershey, Senate Bill 541. And, you have the time that you need, Senator Hershey. You know the drill.
Yes, ma'am. I didn't know, were you introducing the bill itself or am I just okay to go?
You're okay to go.
Thank you very much, Madam Chair. For the record, Senator Steve Hershey here to present Senate Bill 541, which is a bill that should be familiar to a number of members on this committee. This bill simply prohibits the Maryland Transportation Authority from making any capital investments in the John F. Kennedy Toll Plaza or the I-95 Toll Plaza. When this toll plaza becomes functionally obsolete or moves to all electronic tolling, then MDTA must move and establish a new facility at a specified location between Route 272 and 279, further up towards the Delaware border. As a reminder to the committee, the toll facility that MDTA manages is the entire length of I-95 from 695, the Baltimore Beltway, all the way to the Delaware border. Except the actual toll is located at the Tidings Bridge. So it's only paid for vehicles that go into Cecil County. And that's why I have with me several members from the Cecil County Economic Development Team. I also have letters of support from the Cecil County Executive and the Cecil County Council. But why is this important to Cecil County? Cecil County has invested in an economic impact study of the highway tolls by the SAGE Policy Group. Everybody knows them, in 2006 and again in 2015. The study found that there is continuous evidence that the presence of the toll in Cecil County serves to partially separate it economically from the balance of the state. The report specifically mentions the ongoing economic underperformance of Perryville and Port Deposit, two cities right in Cecil County, and the Hollywood Casino. What should also be of interest to the General Assembly is that we've just made a substantial investment in last year's capital budget and this year's capital budget to a project just in Cecil County called the Bainbridge Development Project. So where we are right now, Madam Chair, as I said, I've brought this bill before this committee before. I originally introduced it in 2014 session. We had a new administration in 2015, and honestly, I thought we'd be able to work this out with them. We weren't getting anywhere. I reintroduced the bill in 2017. Again, to serve a reminder to MDTA that we were serious about this and we wanted to see more participation in the relocation of this toll plaza. Once again, I was told by MDTA that they can work that out. This came to fruition again in our CTP meetings that we have in every county. Once again, myself, the Cecil County delegation, all expressed interest again on when we would see the movement of this toll plaza. And the reason that this was again instigated is because the governor has moved finally to all electronic tolling at all of the toll plazas. And this was the exact opportunity that we were waiting for, that when that was going to take place, we did not want to see capital improvements going into the current toll location. And we were very specific all along that when that occurs, we need to move the toll plaza, which is really just the gantry, the toll gantry, to a different location. And unfortunately, there's growing frustration with MDTA. I hate to say, I don't think that they're being truthful, but we have, again, as a result of asking for their, where the status last in October, they came back to us with a brand new requirement that in order to move the gantry to a different location, they would have to go through a NEPA study. And I reminded them that we just saw the toll plaza be taken down at the Chesapeake Bay Bridge. The gantry for the collection of all electronic tolling was moved to the other side of the bridge in Queen Anne's County. A NEPA study was not done through that. In fact, there was really no no conversation about that moving as well. That came as a surprise to many in Cecil County, especially the commissioners there. So they were able to do that. And Madam Chair, I just think it's time. I don't see that MBTA is here in opposition to this bill. I think it's time that we pass this bill and send them the message that Cecil County and those of us on the Eastern Shore think it's very important that we move that toll facility to a place that doesn't penalize people for wanting to enter Cecil County, but they still can get the revenues that they need from the volume of traffic going through 95 up into Delaware and the Northeast states. So with that, Madam Chair, I ask for a favorable report on Senate Bill 541.
Thank you. Let me ask, the fact that MBTA is not here, do you think that suggests that the current governor is in favor of it and wants to help you?
Madam Chair, I don't want to speak for the governor, but I've had several conversations with members of MBTA. They've had two different executive directors over this administration. Both have told me that they certainly want to do this. So I don't know what the holdup is. But I get concerned when I see that facility is moving towards all electronic tolling at the same location. We're not seeing any, I don't want to get to the point where we've made that transition and then they say it's too late. So that's why I think that this is important.
Okay, thank you. All right, let's go to Michael Ratchford. You have 5 minutes. You're the lead proponent.
Okay. Thank you, Madam Chairman and members of the committee. I appreciate the opportunity to appear before you this afternoon. Again, my name is Michael Ratchford, and I'm testifying in my capacity as chairman of Cecil County's Economic Development Commission, and I respectfully request a favorable report on Senate Bill 541. In my day job, I'm a government relations associate with W.L. Gore and Associates, the largest private sector employer in Cecil County. As Senator Hershey has said, moving the tolls to a location closer to the Delaware border is a longstanding request from Cecil County's business community. The current toll plaza location serves as an economic barrier between Cecil County and the rest of Maryland. This barrier is especially significant for Cecil County's small businesses who may be looking for opportunities to do business in other parts of Maryland. Place yourself in the shoes of a landscaping or construction company with a truck and a trailer trying to make the daily commute on I-95. One truck and a trailer could cost you at least $48 a day, and those costs add up for small businesses. The toll plaza location also serves as an incentive for Cecil Countyans to look to Delaware for retail, shopping, services, and jobs. Delaware's lack of a sales tax certainly has stunted the growth of retail business in Cecil County over the years, and the location of the toll only further drives economic activity across the state line. As Senator Hershey has noted, to get a better understanding of the impact of the tolls on Cecil County, the SAGE Policy Group conducted an economic analysis in 2006 and 2015. Those studies found significant differences and anomalies in the economic activities reasonably attributed to the location of the toll plaza. Specifically, SAGE found that the toll location results in economic underperformance of Perryville and Port Deposit, the first two towns in Cecil County after the tolls. When SAGE compared per capita income, labor force participation rates, and median housing values, between Havre de Grace on one side of the Susquehanna and Perryville and Port Deposit on the other, they found that there was higher per capita income, higher labor force participation, and higher housing values on the Harford County side as compared to the Cecil County side. SAGE estimates that if Perryville and Port Deposit were more fully integrated into the state's economy and were equally comparable communities in terms of economic performance, could result in 50% more jobs in those communities, 50% higher payroll per employee, 130% expansion of annual payroll. SAGE concluded that if the toll were to be relocated, the economic gains to Cecil County and the state of Maryland would be substantial. And even apart from the business community's interest, the toll location can be an economic burden for Cecil County's middle and low income families who may have to commute daily to the greater Baltimore area. In sum, the current location of the I-95 toll plaza does serve as an economic barrier between Cecil County and the rest of Maryland. The barrier hits hard on small businesses and working families commuting daily between Cecil County and Baltimore. The toll plaza pushes Cecil Countyans to look to Delaware for jobs, retail, shopping, and services. And the two studies by the SAGE Policy Group demonstrate the adverse impact of the current toll location. For all these reasons, we respectfully request a favorable report on Senate Bill 541. And on the part of Cecil County's business community, I'd like to thank Senators Hershey and Gallion for taking up the cause here. Madam Chairman, that concludes my remarks, and thank you.
Thank you. And I noticed there's nobody signed up in opposition. So Stephen Overbay, you can wrap it up for us.
Thank you. Good afternoon, Madam Chair and members of the committee. My name is Stephen Overbay, and I appear before you today as the Director of Cecil County's Office of Economic Development. And I too respectfully request a favorable report on Senate Bill 541. Being located on the I-95 corridor is and certainly should be considered a key resource for economic growth, providing access to deep water ports, international airports, and supporting commuter and employment travel throughout the region. It remains clear that the existence of this toll impacts Cecil County unlike any other Maryland jurisdiction. Ultimately, this toll turns an interstate mobility asset into a liability for the county's business community, negatively impacts our ability to fully realize tourism success, and unfairly serves as an additional burden for companies in hiring qualified workforce. According to the U.S. Census Bureau, only 11% of Cecil's workers come from Harford and Baltimore counties whose commute require the toll, while 21% enter from toll-free Newcastle and Chester counties. Relocation of this toll would allow Cecil County to fully compete as a regional employment center to benefit the entire state of Maryland. The 2015 toll study by the SAGE Policy Group, that was already referenced, quoted, "There is continuing evidence that the presence of the toll in Cecil County serves to partially separate it economically from the balance of the state," end quote. While I do not believe this was the intent of the toll placement, I do believe the time is long overdue for the state and MDTA to fully recognize the incredible assets Cecil County brings to the table in support of Maryland's economy. The Cecil County business community has continued to thrive despite being the only jurisdiction in the state burdened with such an unbalanced playing field. Against difficult odds, many valued corporate partners have chosen to invest and grow in Cecil County. Coupled with multiple new projects underway like Great Wolf Lodge, Bainbridge, Principio Business Park, Southfields, and more, it is evident that Cecil County is positioned for success. I urge this committee to consider the county's economic growth potential that could be realized should this economic handcuff that the toll represents be removed, allowing for us to finally embrace the governor's motto of being open for business. In closing, Senate Bill 541 will provide significant relief to one of Cecil County's largest economic challenges. On behalf of the Cecil County Office of Economic Development, I urge you to provide a favorable report on Senate Bill 541. Thank you very much.
Thank you very much. Are there any questions? Okay. That's the end of the testimony then on Senate Bill 541. And I noticed there's nobody opposed. So maybe that's a good sign, Senator Hirsch.
Madam Chair, and if the committee would like, it's a future time, I'd be happy to explain the fiscal note to everybody. I won't take up the time here, but believe and certainly have evidence that it's highly inaccurate.
Okay,
Thank
all
you.
right. We'll find the time.
Thank you very much, Madam Chair.
Okay, Senator Reedy, Senate Bill 614. And your lead proponent is Shireen Joseph, and that person will have 5 minutes. All of the other witnesses will have 2.5, and you're on, Senator Reedy.
Thank you very much, Madam Chair and members of the Finance Committee. It's really an honor and pleasure to be before you to present Senate Bill 614. It's legislation that I've been working with, brought to me by a number of folks who are very much impacted by the current state of how our process works with PBMs, pharmacies, and insurance companies. I also am aware from the testimony that we all have in front of us and what I've been contacted by that it's certainly not an issue that is easy or one that doesn't inspire some opposition. So, but I think it's important for us. I've always, maybe coming from the Judicial Committee, viewed us as kind of like a court. You know, we try to weigh the evidence and weigh the issues before us and try to come to a good resolution. And fortunately, we don't have to go guilty or not guilty. We can come up with some sort of settlement a lot of times, and that's what I think the Finance Committee is known for. So I'm just going to go through the testimony and happy to take questions at the end. But I also really want you to hear from the folks who will be testifying that these policies impact. So Senate Bill 614 would require pharmacy benefit managers to report the costs of prescribed drugs to the insurance commissioner for all drugs that were reimbursed by PBMs to pharmacies below certain amounts. So if a prescribed drug, a PBM reimburses a prescribed drug below the national average drug cost plus fee for service professional dispensing fee, the PBM would be required to file a quarterly report that settles out certain information for that drug. The report would include the amount the pharmacy was reimbursed, the NADAC cost on the day the drug was dispensed, and whether the dispensing pharmacy was an affiliate of the PBM. And it would be a filed quarterly report available to the public. So what's the need for this bill and why this report? As I know the members of this committee know, and I'm assuming you have heard in past sessions, but I think it's important to restate there's tremendous concern that independent pharmacies particularly, but pharmacies in general, are not always fairly or adequately reimbursed by PBMs for filling and dispensing prescriptions. So the goal of this bill is to supply transparency to financial transactions between PBMs and pharmacies. A pharmacy's cost for filling a prescription is one, it's dependent on the cost that it pays to acquire the drug, and number two, the cost that is reimbursed for its professional dispensing fee. This bill, Senate Bill 614, would allow the public to see how often and how routinely or not PBM reimbursements fail to fully reimburse a pharmacy for these two components, the cost of the drug plus the fee for the service professional dispensing fee. And it will also allow transparency as to whether the dispensing pharmacy was an affiliate of the PBM and whether the drug was dispensed in accordance with a government health plan. The goal here is transparency for PBM practices and for reimbursement policies. I would respectfully request a favorable report on Senate Bill 614, and I'm happy to work with both the proponents, of course, and also the opponents of the bill or those who have concerns to see if we can work out a way to have more transparency in the process as we seek to make sure there's a fair and equitable distribution for all the pharmacies in our state, whether they're a chain or whether they're an independent. So with that, Madam Chair, I'd be happy to turn it over to other witnesses.
Okay, and I guess you're aware we've been losing pharmacies at a terrible rate in Maryland for the last few years, largely because of the bad relationship between them and the PBMs and some of.
I am, and I can tell you, I was going to probably mention this on the next bill, but both bills sort of are impact this discussion. I mean, I have a community with a lot of small towns, and we have a proud tradition of independent pharmacies. We have chains too, and I'm not anti-chain by any means, and I sometimes will frequent a chain for for pharmacy needs. But you know, some of the independent guys in little towns like New Windsor and Manchester and places like that in Carroll County, and in a lot of communities around the state, it's becoming a more difficult. But they're an important point of access. There may not be a chain in the same town. Somebody may have to drive several miles to get to the next thing. So we want to try to be, again, not trying to stack it one way or the other. We just want things to be fair. So that's really the genesis of the bills. So thank you.
And these bad vibes going on, this costs us to lose service. I think we've lost almost 500 small and independent pharmacies in about the last 4 or 5 years. Yeah.
Mm.
Okay, we're going next to Shireen Joseph, and you have 5 minutes.
Madam Chair, can you hear me?
Yes.
Okay. Thank you, Madam Chair and the members of the Senate Finance Committee. My name is Sharon Joseph, and I own a small pharmacy in Baltimore, Maryland.
You do have a tiny voice, though. Project a little bit or get closer to the mic.
I'm here representing the independent pharmacists of Maryland. I want to thank Senator Reedy and the sponsors and supporters of this Senate Bill 614, which I'm testifying in favor of. For the past couple of years, we've been telling both the House and the Senate committees about how pharmacies, and especially the independent pharmacies, are being reimbursed below cost on an increasing percentage of claims, which is slowly forcing us out of business. In a few minutes, you'll hear from one of our own who had to close her pharmacy as she could no longer wait for the help we all are waiting for. This is 15 plus years of her hard work and life savings gone, and she's forced to look for a new avenue for herself and her child. This is how Maryland would like to award or reward its small businesses. This bill, SB 614, can finally shed some light on what is really going on by mandating the PBMs to report when they knowingly underpay pharmacies for the prescriptions we provide to your constituents. We are not asking for any proprietary information, as the PBMs might claim this bill to be, but for the percentage of claims that is paid under cost to its affiliate versus that to an independent. This committee can finally see in black and white the after effect of a payer who is also the direct competition being put in charge of reimbursing its payee. Over the years, PBMs have evolved from paper pushers to significant controllers of the drug pricing system, a black box understood by almost no one. Lack of transparency, unjustifiable fees, and massive market consolidations have made PBMs among the most profitable corporations. Insurance companies empowered PBMs not only to pay pharmacies, but to decide how much money they should receive. The problem is that over the years, reimbursements have been shrinking to the point that we are not receiving enough to cover the original cost of the drug nor the overhead. There's a huge amount of secrecy that surrounds how PBMs operate. The details of the contract they write, the formulas they use to calculate reimbursements are often insanely complicated, and this leads to situations where pharmacies are losing money on prescriptions they dispense. 3 PBMs control around 75% of the market. So if pharmacies want access to all those customers, they have to accept the PBM terms, and these terms are always one-sided, take it or leave it ones. Every time we ask for regulations on PBMs, the rebuttal they give is that they're saving money. But who has seen these savings? Year after year, we see premiums going up, deductibles going up, copays going up, the formulary lists are being shrunk, and the independent pharmacists going out of business. The only thing that has gone up is the compensation to their CEOs. In fact, the states who took PBMs out of these equations, like Ohio, West Virginia, and many other states, are actually seeing tremendous savings to their states. A third party that was developed to decrease drug cost has morphed into the reason why the drug costs are so high for the employer and the employee. And every time we identify and solve one problem is only to chase another one brought forth by the PBMs. So the lack of transparency in the largest PBMs and the lack of meaningful competition negatively affects patients, pharmacists, insurance plans, manufacturers, and ultimately taxpayers who fund government-sponsored healthcare programs. And as for me and my independent friends, this has brought a tremendous amount of stress. Sleep sometimes is an issue, as our minds racing with the thought, would we also have to fold soon? Our years of hard work, life savings, the legacy we would like to leave our children is all at stake here. We are not looking to make 36 million or 22 million or 15 million like some of the PBM CEOs does. We are looking to make the cost of the drug plus the dispensing fee put forth by the CMS. Through the reporting that we are proposing here, the MIA can see the below-cost reimbursements and take necessary steps. So we humbly request this committee to give a favorable outcome for SB 614. Thanks again for your time and this opportunity.
Thank you. Before we ask for questions generally, do you have any written description of what reforms have occurred in West Virginia or in Ohio as you cited? Can you hear me?
Yes, we can get it to you. We can.
Okay, would
Can
like
we
to
email
see
it to
what
you?
they've done.
Yes.
Okay, thank you. All right, are there questions for this witness? Okay, if not, then we're going to Deepak Kitty.
Hello, Madam Chair. Thank you for giving me the opportunity. And thank you to the committee for hearing our testimony. My name is Deepak Kinney. I represent Hillcrest Pharmacy and Compounding in Frederick, Maryland. A small pharmacy, but a proud member of Independent Pharmacies of Maryland. I thank Senator Reedy for his sponsorship and everybody who is supporting this bill, and all the Senate finance and senators who are supporting small businesses like independent pharmacies in Maryland. Year after year, you've given us support, but year after year, it's made these PBMs have made these practices so opaque, it's very hard to get forward. This year again, we're asking for a favorable report on this bill, which is going to bring some amount of transparency into the pricing structure. And we finally want to show that they are really paying us below cost. These entities, the PBMs, neither produce a drug, neither distribute a drug, they don't dispense a drug, they don't take part in any patient activities, yet they are the ones who make the most money. And every time you try to bring a bill, all they have to say is, oh, it's going to increase the cost, and everybody is quiet. It's like a chilling effect. That's all they have to say, calmly, oh, it's going to increase the cost. Because nobody knows how it's going to increase the cost. And like Shireen said, every year prices are going up. The bill is plain and simple. If they say there is proprietary information, if you give claim level detail, then let us give percentages. Forget about the claim level detail for each below cost claim. Give me a percent of claims that were paid below cost for each drug, and whether the pharmacy was affiliated with the insurance, with the PBM, or was it a non-affiliate? And then give me a claim level detail for each drug, whether the drug was filled at the affiliate pharmacy or non-affiliate pharmacy. When you see these details, you will see that A, they're paying us less, and there is no firewall between them and their affiliate pharmacies. They're titrating the payments based on where the claim is filled, at their pharmacy or not at their pharmacy. All these things will be revealed. The data will reveal so much information that you will know that they are doing anti-competitive practices. That's it. That's plain and simple. And we would like the MIA to have some authority over these PBMs to check for malfeasance in the reporting. That's just a thought. But we know that there is, for years, that there is something going on, and this bill will help in revealing that. They'll also claim, the opponents, that NADAC is an arbitrary pricing system and pharmacies make more money, blah, blah, blah. This is a starting point. We just want to show the differences between the affiliates and non-affiliates and what the PBMs are doing. That data can be further used by this committee or the senators and the delegates to help us, small business. Let's start somewhere, and let's start with this bill. I hope it will have massive support with you guys, and it'll show that the anti-competitive practices that are going on in the marketplace. Thank you for your time, and thank you for providing this opportunity.
Thank you. Are there any questions of this witness? Okay. We're going next to Aja Kumar Sharma.
Thank you so much for your time today. My name is AJ Sharma. I'm the pharmacy owner at Little Acorn Pharmacy in Silver Spring, and we're in Montgomery County. What I'd really like to talk about is the same as what they said. I mean, I don't need to reiterate what they've told you. What we should do in Maryland is we should have active oversight over these bad payments. First of all, they have contracts that are, it's a take it or leave it contract. You know, you have to sign it or else you're not going to have any business. And we know from the audit that happened a couple of years ago that CVS Caremark was making about $8 a claim. Meanwhile, they're paying the pharmacies about 30 cents for each prescription we fill. And, you know, I know it requires money to do what they do, but to be paid more than the cost of the drug and actually talk to the patient and see the patient and provide a service is unheard of. And, you know, what I think of it as, you know, when I took accounting classes and when I was getting my master's degree, is shenanigans in accounting. This is really, truly shenanigans in accounting. And no matter what people say, things have to be accounted for. This is shenanigans. They have games. These games are unfair. They're only fair to their own companies. In the meanwhile, in their back offices, they're collecting rebates from drug companies. And that's something you don't know about. But if you read David Dian's report about these kind of payments, you'll understand it's big money. And they don't want to share any of the money, not even with the insurance companies. So if the insurance companies are here to say, oh my goodness, this is going to be, you know, a lot of back office work for us to do, it's not true. What I really want is for all the payments to be monitored by the state of Maryland so that, and it's going to cost money. And I've spoken to Mr. Guzon about it, my senator, and I also wanted to talk to Mr. Feldman about it. I have a 30 cent per claim fee for service in the state of Maryland so that we can fund MIA to have someone watch claims and use a computer. It's a novel idea, but it's being done all the time, and they watch us and they conduct audits on us all the time. And why don't we audit them? They have millions and millions of claims, and they do a lot of these things unfairly, and they've been caught. They've been caught by the federal government. CVS Caremark since 2000. All you have to do is Google it, say how many fines have they paid? They paid over $1 billion in fines. How many did they pay to the state of Maryland while they cheated our businesses here? Not much. So that's what I wanted to say.
Okay, let me ask you a question. The last time this committee that I recall had a hearing on this general subject, we heard about some other problems with PBMs from the perspectives of the independent pharmacies. Do they constantly change the terms of your contract within a contract year?
It's interesting. The terms don't change. They can change year to year, but what does change is the MAC pricing. Like this year, I must have gotten 10 faxes from Optum, and Optum is one of the large PBMs. Optum will send you a fax at the beginning of each week and say the MAC price has changed. That means the maximum allowable cost has changed. But interestingly, the NADAC hasn't changed. And so they say we shouldn't go by NADAC. Well, let me tell you what NADAC really is. NADAC is me and other companies sending in our wholesale prices to the federal government. That's how they come with NADAC. Now, how they come up with MAC, you can just take a guess.
Is the situation for those of us who are not in this business that independent pharmacists can't really get what they need from the drug manufacturers except through the PBMs? Is that the situation?
Are you saying you have to join a PBM?
Well, I'm asking, do you?
Is your question
in order
that
to get the merchandise that you need in a timely manner, do you have to?
Oh, no, you have to have a wholesaler. Yes.
Well, that's what I'm asking.
Oh, yeah.
And that's
like everybody.
And that's the role of the PBMs.
So the role of the PBM is just billing and not the actual medicine itself. They're a middleman. They're a middleman between the insurance
That's what I'm
company
really
and the
trying to get
pharmacy.
at. You can't buy and sell and account directly with the drug manufacturers. You have to go through these middlemen, these PBMs.
Well, no, it's different. Like I purchase from my wholesaler, and they pay us depending on what they think we purchase it at. So their two are not related.
Okay. Thank you. All right, let's go next to Elnaz Darji. You need to unmute yourself. Unmute yourself. We can't hear you. Can you unmute? Okay, now that's fine.
Good afternoon, Honorable Chair and the members of the committee. I was here to testify in favor of Senate Bill 615. Is that correct? Am I understanding? Because we just moved on to 615.
Well, we're still on 614.
Wait a minute, no,
I
we're
was
on
signed up to
614.
do 615. That's what my understanding was.
She's on both bills.
Oh, you're on both bills. You signed up for two bills, did you?
Yeah, but I was informed from the chair of our group.
Well, right now we're on 614. Do you have something to say about the PBMs and how they are treating independent pharmacists?
I can definitely add something to what my colleagues just said, and then I will give my full testifying on the 615 later on, if possible. I wanted to thank you all for your time. I'm in favor of Senate Bill 615, and to the answer of your question, Senator
Well,
Kelly.
right now you're testifying on 614.
614. And that is the role of PBMs. And you were asking about that question. Here's what's happening. In order for us, independent pharmacists, any chain drugstore, to be able to bill their claims through main providers, we must go through PBMs. This is something that's been forced upon us. They're middlemen. They have nothing to do with drug purchasing, drug dispensing, anything whatsoever. However, we are mandated to sign a contract with them, which all of the terms of those contracts favors them. And year by year, there are changes happening that are reducing our reimbursements, which is at the present moment, 80+% is below cost. And that's pushing our businesses out of business. And that's what they want. The other thing is their common interest and ownership with some pharmacies. One of the biggest PBMs in the country, who is actually the owner of, or vice versa, the biggest chain drugstore. How is that not a conflict of interest? And that's what I need to add to this particular bill, that I'm in favor of it. And I hope that everybody else in the member of the committee and everybody will find it in their heart to support and vote in the favor of 614.
Madam Chair, I didn't want to jump into the people who are the experts on this. I did want to say, yeah, it's basically the PBMs, and I'm learning more about this all the time myself. I had to brush up on my PBM knowledge from back in the HGO days. They're a middleman between the insurance company and the pharmacy. So they don't really deal with you procuring the drugs, but they're the ones who are setting the price and dealing between the insurer and the pharmacy. And a pharmacy has to go through PBM in that relationship. So.
And okay, that's helpful. All right. Well, you were the one to be, no, we have one other person on this bill. Heather Casconi is unfavorable. We have 2 or 3 others. Okay, and you're next.
Thank you, Madam Chair. Members of the committee, thank you. My name is Heather Cascone, and I represent the PBM industry through its trade, the Pharmaceutical Care Management Association. I appreciate the opportunity to speak to you all and raise some potential issues with Senate Bill 614. 614 would require PBMs to file a retrospective 3-month report of reimbursed claims. that are less than a benchmark chosen as NADAC, which is a self-reported price. The national average drug acquisition cost, or the acronym NADAC, is a voluntary national survey of pharmacies who are willing to self-report their invoices for their drug dispensing claims to CMS. These pharmacies submitted invoices include prices that do not reflect any discounts or rebates or price concessions that the pharmacy may have received. And as a result, they're not indicative of the true cost of dispensing the prescription drug. Instead, they can be artificially skewed to a higher rate. Because NADAC is self-reported, which means that pharmacies are not obligated to report every claim, nor are they obligated to report all of the invoices for the drugs that they dispense. It allows essentially selective invoices to be reported. In utilizing NADAC as a reference price in the context of this proposal, the state of Maryland would be comparing claims to the highest cost possible for the prescription drugs that have been dispensed. Additionally, NADAC is recognized as being flawed in that it is retrospective. It's a retrospective look at drug pricing that often lags so much that it can be inaccurate to current pricing levels. One of the previous speakers mentioned that MAC prices change very frequently. Well, that's very much true. The marketplace acts in many instances like a commodity market. Prices can change on a day-to-day basis, and so it's extremely important that when we use a reference price, that it's up to date and timely. In this commodity-like market, drug prices change weekly or daily, and a price could be completely irrelevant by the time it's reported to CMS and then used as the NADAC price. It's for these limitations and the fact that this proposal could arbitrarily skew prices higher in the long run, it raises potential questions as to who would like the state to use this kind of model and why. And so
I wish we had longer. Your time is up if you could wrap up.
Thank you for the time. I appreciate it.
Okay, thank you. All right, we're going next to Camille Fetch.
Thank you very much, Madam Chair, Mr. Vice Chair, members of the committee. Camille Fesh here on behalf of PCMA, opposed to the bill. A few more things to add to Heather's testimony. More to explain where PBMs fit into the drug supply chain. So you have, usually there is an employer or a payer, so a large company or the state of Maryland or somebody else that is putting together the health insurance plan. They contract with a health insurance company, which is a company, the health insurance company sets the reimbursement rates for doctor's visits. There's also usually a PBM, pharmaceutical benefit manager, which is the insurance company that sets the reimbursement rate for pharmaceutical drugs. The role of the PBM is to fulfill what the payer or the usually large employer or government entity that puts together the plan, to fulfill what they are looking to accomplish in their plan to serve the people that are in the plan, the ultimate enrollees. So the PBMs do not handle the drugs themselves. They simply set the reimbursement rates. And this means that the PBMs do engage in contracts with the various pharmacies and with PSAOs. A lot of the independent pharmacies, not all of them, are members of large PSAOs like Epic Pharmacy, and the PSAO on behalf of the independent pharmacies that that contract with them, do contract with the PBMs and agree to reimbursement rates and terms of the contract. It's not required that any pharmacy sign up with any particular PBM, but it is possible that they can. And usually there are large groups that negotiate with the PBMs. And again, the role of the PBM is to lower the cost of the drug prices and to fulfill the terms that the carrier or the ultimate payer, the employer or the government entity, is looking to accomplish with the plan itself. And with that, I'll turn it over to Mr. Johansson and happy to answer any questions.
Yeah, why do you think all of these independent pharmacies are so unhappy with you? Do you think they have any point whatsoever, or if you were in their shoes, you would be happy?
I can't opine why anyone would be happy or unhappy in a particular business environment, but I mean, the number of independent retail pharmacies in the state has not declined. It's actually increased over the past several years. And the number of chain pharmacies has remained the same over the past several years. And this is information pulled from the National Council for Prescription Drug Programs. The role of the PBM is to provide, the reimbursement rates, and the role of the PBM is to decrease and hopefully decrease the price of the drugs for the enrollees, the you and me, when we go to the pharmacy counter. So I can't opine on how anybody feels about it, but that is the role of the companies.
But as middlemen helping other entities to decrease prices, you make more than they do who actually provide the service to the patient, right?
I can't opine. I mean, I turn it over to Heather from PCMA to answer.
You guys are smart, come on. Okay.
I'd be happy to answer.
Let's go to Michael Johansson.
Thank you, Madam Chair. Mike Johansson again on behalf of PCMA, and I won't be duplicative. So this information is being requested for the purpose of demonstrating that in many cases or some cases, PBMs pay less than what the NADAC schedule plus a dispensing fee would. You don't need to find more information. This has already been studied by the Department of Health and Mental Hygiene in 2018, where they did acknowledge that in some cases, the PBM pays more for the drug than what the NADAC survey does. And in some cases, the PBM reimburses less. In many, if not all cases, the PBM has a lower dispensing fee than the $10 dispensing fee under the state's NADAC schedule. And the Department of Health estimated that if the General Assembly wants to go to NADAC pricing for pharmacies, in the MCO program of Medicaid, it would cost the state of Maryland $70 million a year. The Department of Budget and Management estimated that if the state of Maryland wants to pay NADAC pricing to pharmacies, which you can mandate for the state employees plan, it would cost between $23 million and $45 million a year, depending on the dispensing fee. That's a year, just to pharmacies. And under the state employees plan, for example, the employees and retirees pay 20% of that cost, which would be between $5 to $9 million more going to pharmacies out of the pockets of state employees and retirees. And the last thing I'll say about where the money goes is very important. 70% of the prescription drugs go to chain pharmacies. So in this situation, rather than independents, so is it better to pay Walmart and Safeway and Costco and Giant more money? That's because that's what these bills do once you collect the data and they come back and say, give us a pay raise. And remember, it is not the PBM's money. When a PBM has a contract with the state employees health plan, it's the state's money and the employees' money. They're paying 20% of it. If we have a contract with Care First, it is the businesses who are paying Care First for premiums. These bills don't take away PBM money. They take away the money of the companies that we are working for. So we don't think this bill is necessary. This is a massive data collection effort that violates a lot of proprietary and confidential provisions. And if you want to know what it would cost to go to NADAC, the state has put that in writing in 2 fiscal notes on other bills in the House.
That's good testimony. Let me ask you this. In rural areas where you don't have a lot of chains, are there accommodations that need to be made?
I think there are. And here's an example where the General Assembly worked with Maryland Medicaid and came up with, just for a small set of rural pharmacies, an additional dispensing fee. And if, for example, the State of Employees Health Plan wanted to do that so that they could make sure there's access in those areas, they can do that. So it always comes down, however, to not something that the PBM has to implement, has to really burden with. It's the company who's paying the bills. So you can do targeted programs, and you have a good example of one with Medicaid where they did exactly that.
Thank you. Are there other questions? Senator Reedy, did you have a question?
Yeah, just I think two questions. One maybe to Mike, and then actually Heather maybe had a question. But Mike, isn't part of the concern, and I understand these issues, you know, they're not cut and dry, but isn't part of the concern, at least what I hear a lot, is the feeling that it's a bit abstract in the pricing. So one day it'll be at that level, NIDAC, and then another time it won't be. And there's not a lot of visibility in how the decision gets made. And so small pharmacies feel like and it can be punitive even if they're you know, pushing sort of against the system. And can you speak to that?
So the General Assembly over the last couple of years has given the Maryland Insurance Administration more power to conduct investigations. So pharmacies are allowed to file complaints, and the pharmacies actually, you know, fought for these rules over the last couple of years, and finance and HGO worked it out, and they exist. So I think MIA should be consulted how many pharmacies are actually filing those claims. But I do think the other confusion comes in because of the Supreme Court and ERISA rules. You know, some of the payment plans are different and covered by federal, you know, ERISA proceedings and not by state law. So there's only a portion of things that are covered by MIA, but we can't change that, right? I mean, the Maryland General Assembly can only do so much when it comes to ERISA exemption and things like that. But I would suggest MIA does have investigation power, and Commissioner Redmer fought for those powers when he was commissioner. And I'm sure the existing commissioner would say that she has the authority to take action if she finds a problem.
But it's not your view. You would argue that your industry does not engage in any sort of abstract, or I mean, that there's a rationale for every price that's given.
I think the companies abide by the contracts they have with the pharmacies that they're paying, and I would hope that they are, you know, conducting business in the appropriate way.
The problem is that you're forced to enter into contracts as it, but
listen, I mean, doctors in the state of Maryland would tell you that if you're not with Care First, you're not going to get enough patients. Yeah. So have we ever said to Care First that you can't, you know, you've got too much pressure over these doctors? Frankly, no, we've never said that.
Well, Care First, but we have an HSCRC that well, anyway, I won't get into that.
It's a different group. There's no regulation of provider fees and insurance companies. Is it?
Okay. Madam Chair, I had another question possibly, but I'll just hold off. I know we're getting late, so thank you.
Thanks. Okay. We're going to Matthew Santana.
Thank you, Madam Chair, for the opportunity. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers to aid American health insurance plans opposed to Senate Bill 614. I will be brief, and I want to just give you their carrier perspective. We are concerned about the precedent of publishing specific healthcare data. It's also relative reporting using the NADAC as a benchmark, and we suggest that it's anti-competitive. It takes proprietary information and immediately puts it on a public website for all. We're worried that the release of this information could lead to price increases, which would have upward impact on healthcare premiums, which we all do not want to see. So for those reasons, we're unfavorable on Senate Bill 614.
Okay, any questions for Matthew? Okay, thanks to everybody who has testified on this bill. I think we know more. I'm not sure if we're smarter yet or not. But, okay. All right, we're going next, a little out of order, to Senator Kagan because her committee is about to vote. So Senator Kagan with Senate Bill 580, and then we'll come back, Senator Reedy, to your other bill.
Thank you so much, Madam Chair, Mr. Vice Chair. Thank you, Senator Reedy, for your deference. I'm going to be pretty quick because this isn't that complicated a bill. We all know that climate change is causing Cheryl Kagan, very proud to be the senator for Gaithersburg and Rockville, with this bill that came from a constituent, a Rockville constituent. We all know that climate change is causing increasing problems in our neighborhoods and with our homes as a result of fire, flood, hail, and others. people are filing claims. They've done nothing wrong, and the damage is not preventable. Sometimes those claims are paid out. Sometimes they are not, and they're either withdrawn or rejected. What happened to a constituent of ours is that there were 3 weather-related, not preventable claims that they filed, and the insurance company canceled their policy. No advance notice, no warning, and suddenly they are not covered. And perhaps if it was a small claim, they might have just said that they would not even file it if they knew that they were at risk. So, so first off, I want to flag Mark Silverman's written testimony for you. He was not able to join us on video, but I do encourage you to read his story. So this bill just says that you can't cancel based on 3 weather-related claims in a 3-year period, that there has to be a notification of cancellation. And this is slightly modified in a way that I think folks are finding more acceptable and more of a middle ground. Last year, it was voted down by Economic Matters. This year, they have just reported it favorably. So I think this may be more to your liking. I am going to defer. I have 2 witnesses. I'm delighted to have my old friend, longtime friend from a million years ago, John McLean from the Attorney General's office, who will be the primary witness. And then one of my talented interns, Evelina Sarape, will share her brief testimony afterwards. With that, thank you, colleague.
Well, I do have one quick question for you before you go off the vote. Not more than the 3 claims in a 3-year period that are weather related.
Yes, ma'am.
If it turns out that the homeowner is leaving the house in some aspect of the engineering of the house in disrepair or in a vulnerable position, should this idea hold?
I think that's a great question. I think we're talking about not preventable. So if there's something that the homeowner could do to prevent damage, I think the homeowner should be liable, and that would not be covered under this bill. And if you don't think the bill as drafted makes that clear, a tightening amendment, clarifying amendment is totally in order.
Okay, that was my question.
Yeah, great question.
Question of the sponsor before she goes off the vote.
I can wait.
All right, Senator Battle has one question.
Thank you, Madam Chair. Thank you, Senator Kagan. So in your early comments, you said they received a cancellation without notice. You didn't really mean without notice, right? I mean, they got the required 45 days from the insurance commissioner in writing and a certified letter.
Sorry, hold on. The testimony from our constituent was about not having sufficient notice. And I don't know whether, right here, current Maryland law gives homeowners the right to a hearing. He only had 2 claims. There was no payout. And the Maryland Insurance Administration ended up ruling in his favor, and Erie had to reissue a new policy. But here we go. November 2018, he received a letter, 9 pages of documents. I'm sorry, I don't remember that aspect. And he
did say that the MIA ruled in favor of your homeowner.
Yeah. So ultimately, the Maryland Insurance Administration did rule in favor. Senator Bidel, I think his argument was that it was confusing and didn't offer him the information he needed. I suspect Mr. McLean might be able to navigate that one a little bit.
I just don't want the committee to think that policies get canceled without notice. There is Maryland law that requires 45 days written notice with an opportunity to appeal. So I just want to be clear on that, Senator Kagan. Thank you.
Thank you, Senator Bidel. And he did appeal, and they ruled in his favor, as I said. So that was important. Sorry.
Proper process.
Okay. Sorry, I didn't have that answer.
Okay. All right. Now the 5-minute witness is John McLean, and we will hear you now. Mr. McLean, you got to unmute yourself. We're waiting to hear you.
There we go. Okay, I tried, my computer froze up a little bit.
Okay.
Good afternoon, it's a pleasure to be here today. My name is John McLean. I'm with the People's Insurance Council Division of the Attorney General's Office. I'm an Assistant Attorney General within that division. People's Insurance Council is in favor of this bill on behalf of Maryland consumers. I think it clarifies how companies can use claims for purposes of cancellation or non-renewal. And I think to clarify a little bit to Senator Bridle's point, I believe that the notice requirement was fully complied with by the company in this instance. The problem was that Mr. Silverman had 3 matters that were treated as claims within that 3-year period. On 2 of them, the company paid out an amount of money to settle the claims. On the 3rd one, the company made no payment on behalf of Mr. Silverman. I believe it was ultimately less than the deductible, so there was no payment made out to Mr. Silverman, but that still counted as a claim for purposes of the 3 weather-related claims within 3 years. I believe this bill would rectify that situation in that if the dollar amount is either less than the homeowner's deductible or does not result in any payment out to the homeowner on behalf of the homeowner, say to a contractor, then that could not be used as a claim for purposes of cancellation or non-renewal. And for those reasons, I think it's an important means to clarify how companies treat these matters that are brought to them as claims.
Okay. Well, that,
and again, the rest of the bill, I believe the bill's pretty straightforward. Pardon me?
I said that is clarifying information, yes.
Okay, and I'm certainly available offline if anyone wants to email me. I'm happy to answer questions. I know this is a difficult time for everyone doing this remotely, but I can provide my email address to your office, Madam Chairman, if that would be helpful.
Okay, thank you. Thank you.
Okay, again, we encourage a favorable report on the bill.
Okay. Let's go next to Evelina Serapi.
Thank you, Madam Chair, and good afternoon, Senators. My name is Evelina Serapi. I am an intern for Senator Kagan, and I'm testifying in favor of SB 580. Senators, as we know, climate change is a real threat within our communities, and it would only continue to escalate at alarming rates. And we need to make sure we are making policies and weather-related insurance policies that will correlate with the drastic effects that climate change is having in our communities. Current law provides that homeowners insurance companies have a right to cancel a policy for a policyholder if they make 3 or more weather-related claims within a 3-year period. This law does not only fail to protect our consumers, but it is also outdated because climate change is going to continue rapidly occurring, and this weather-related events will only continue to occur. As, for example, a study from the University of Maryland showed in regards to Annapolis, since the 1950s, Annapolis has had an increase in its flood days from 3.9 to 39 per year. And this is why I am strongly in support of SB 580, because it will prohibit insurance companies from canceling a policy if a policyholder makes 3 or more related claims, weather-related claims, within a 3-year period for events completely outside of their control and for events that are completely unpreventable. And this bill would not only protect our consumers, but it would also provide them with transparency, because it will clarify that a weather-related claim resulting in no payout to the customer does not count towards the cancellation or non-renewal of their policy. Senators, climate is rapidly changing and it's affecting our communities, and we need to respond quickly. And this bill is the response our state needs. And neglecting the threat of climate change and the drastic increase of weather-related events will leave our communities extremely vulnerable. And that's why I urge for a favorable report of SB 580, because I believe it is the protection that our communities need. Thank you for your time.
Okay, you make your case. It does occur to me that given where you have documented or found documentation of the climatic changes are causing the increased frequency of such events, they probably would do well to look again at the premiums they're charging up front and to be sure they're adequate in the first place, because in some way or another, they're going broke if there are many more climatic instances of situations they've got to reimburse for when it's not anybody's fault. And if we left the premiums the way they were decades ago when there were fewer such climatic incidents. You don't have to answer, but that's occurring to me. Okay, and I'll call you, Mr. McLean, to see what you think as People's Insurance Council there. Any other questions? Okay, we're going next to Evelina Sarapi. Oh, okay, to Robert Enton. He's not here. What about Andrew Kirkner?
Madam Chair, I'm here.
Okay.
Thank you, Madam Chair. Andrew Kirkner on behalf of the National Association of Mutual Insurance Companies. It's a pleasure to be back before the committee today on behalf of our 1,400 member companies, 11 of which are domiciled in the state of Maryland. I would, Madam Chair, if you don't mind, just like to clarify the current status of Maryland law on weather-related claims. Maryland has one of the most restrictive weather-related claims laws in the country. And it says to insurers that they cannot cancel or non-renew unless there are 3 or more weather-related claims in a 36-month period. This bill, in essence, would tell an insurer what it can and cannot consider a claim. So I think that is a helpful framework to review the bill through. In that sense, I don't believe it is a clarifying change. I believe it does change the substantive law in Maryland. I would just say to the committee, insurers do not want to cancel their policyholders. It is very expensive for an insurer to recruit a new policyholder. Existing Maryland law does provide adequate protections with that 3 claim in the 36-month period rule. And so I really, candidly, it sounds to me like the impetus for this bill was resolved through the MIA, through the appropriate existing framework in Maryland law. And so I'm not sure, that this bill would fix an issue. And so finally, Madam Chair, I would just say to the committee, this is precisely the role of agents, whether those are company agents or independent agents. If a consumer has a claim, what they should do is pick up the phone, talk to their agent and say, is this a claim that I should file? What are the ramifications if I do that? So respectfully, Madam Chair, and I'm happy to answer any questions, we would ask for an unfavorable report on the bill.
Okay, are there questions? Okay, I don't see any at this time. Let's go to Nancy Egan.
Good afternoon, everyone, members of the Senate Finance Committee. My name is Nancy Egan, representing the American Property Casualty Insurance Company. We write 60% of the property casualty market within the United States. Before I start my testimony, I just want a clarification that yes, they were given proper notice. The insured did receive administrative hearing. The administrative judge actually ruled that the one claim that was looked at was just an inquiry and not an actual claim, and their homeowner's policy was reinstated. So I just wanted to clear that information about that one consumer. In addition, as Mr. Kirchner already said, Maryland has a viable market. There's 136 carriers writing in the marketplace now, and we rank 30th in the country for our rates. And we are in the minority of only permitting 3 weather-related claims. If you look at Delaware, they have similar law saying that you have to have 3 weather-related claims within a 36-month period. But DC says you can cancel with 2. Virginia has nothing, West Virginia 1, and Pennsylvania has nothing. In addition, the insurance code says that if a consumer contacts their insured and makes an inquiry, that cannot be counted. In addition, when they're looking at those things, they can use mitigating factors by the company. They can offer higher deductibles. They can also say, did they do any mitigation? If there was trees around the property, perhaps they cut them down. Those are all things that can go into the decision of the insurance company before canceling. And in last year's testimony, the insurance administration said they had 114 inquiries from consumers about homeowners cancellation. 5 of them were due to weather-related claims. So that's a very small percentage of all the consumer complaints. I do want to point out one thing, that in 2012, there was 2011, there was a hearing on coastal insurance, about the availability of coastal insurance. And I think many of you may have remembered this. This was back after 2 of the largest carriers, representing 36% of the market, wanted to remove the ability to write in certain areas. That was Anne Arundel County, most of St. Mary's on the coastal area, Ocean City, and a lot of the coastlines, not just in Anne Arundel County, but all along the Chesapeake Bay. There was an inquiry, and that's one of the reasons why we continue this practice of being able to cancel after 3 weather-related claims, so that the majority of homeowners can remain in the standard market instead of going into the non-standard market, where many of the people in Ocean City are currently having some of their insurance. So we want to make sure that the standard carriers are writing the insurance for all homeowners in the state of Maryland. And with that, I'll take any questions.
Are there any questions for Ms. Egan?
Senator Vital.
Senator Vital.
Thank you, Madam Chair. Ms. Egan, thank you for your testimony. Looks like the bill says they can't cancel if the claim was weather related, if an amount is less than the deductible, which means they wouldn't pay anything, or resolve with no payout. So an insurance company could still cancel with 3 claims as long as it wasn't one of these 2 items. Is that correct?
Yes, that would be correct.
Thank you.
Okay, but because we've got a robust market with what, over 136 companies, if they were canceled, they probably, in a case like this where it was due to no fault of their own, it's weather related, and if they have done necessary mitigation, would I assume not be canceled.
Yes, that's correct. It's up to each carrier to look at that. And for example, if you've been with a carrier several years, they're going to also take that into account. If you've been with them for a while, each case is individual for whether a company will cancel and what the consumer has done to, like we have said, mitigate losses, et cetera. And one more thing.
Last question. With regard to these weather-related claims, what would be typical mitigation that a careful and concerned homeowner ought to consider?
One thing I just mentioned, and Mr. Kirchner could, if he wants to join in too, one thing would be about trees around the property, especially in older neighborhoods. I think you're all aware, especially like, for example, in Baltimore City, we had the derecho. A lot of the homes in Baltimore City suffered a lot of damage because of that unusual windstorm. And there was a lot of trees that were falling. We've seen those type of wind events that have caused a lot of damage. So removing trees that are close to the house would be one example of mitigation.
Okay. If there are no more questions, that ends the testimony on this very interesting bill. I think we all learned a lot.
Thank you very much.
Yeah. All right, we're going back to Senator Reedy. What did we do?
We did 14, we're gonna do 15.
Okay, we're going to Senate Bill 615, Senator Reedy, Pharmacy Benefit Managers Prohibited Actions.
Thank you. Thank you, Madam Chair. And again, members of the committee, I know we took a little break. We're still on, it's still PBM day, I guess, today. Have some issues that we want to discuss with this legislation. I would argue this legislation is probably even a little bit weightier with the issues than the previous one, which was more about transparency and sort of getting some reporting. This bill delves into a little bit more of the guts of some of the issues that our small and independent pharmacies are experiencing. And so I'll just go ahead and get started. Senate Bill 615 would add to the statutory list of prohibited acts by PBMs. It would add diminishing reimbursement to a pharmacy based on patient outcomes. It would stop the practice of spread pricing. It would deny the right of a pharmacy to participate it would stop it from denying the right of a pharmacy to participate in a plan if the pharmacy agrees to the terms and conditions of a plan. It would also forbid PBMs from setting different fees for a copay based on whether the pharmacy is an affiliate of a PBM. And it would restrict PBMs from having a requirement that the beneficiary of a plan use a mail order pharmacy. So what is the need for this bill? And we've been delving into some of these issues in the previous bill. The bill would prohibit unfair, anti-competitive, and anti-consumer practices by PBMs. For example, PBMs should not be permitted to reduce reimbursement to a pharmacy based on patient outcomes. Spread pricing, which I discussed a moment ago or mentioned a moment ago, it reimburses PBM reimburses a pharmacy for a lesser amount than it is paid for the drug by the insurer or prescription plan, and in pocketing the difference. PBMs should be required to permit any pharmacy to participate in a prescription plan if the pharmacy is willing to accept the terms and conditions of the plan. Consumers want the choice of having prescriptions filled where they choose, and this bill allows that. Copays should be the same for all pharmacies. PBMs should not be permitted to favor a pharmacy affiliated with them by setting a lower copay at these pharmacies. And finally, and again, they shouldn't require mail order pharmacies. This should be the choice of consumer, not a requirement imposed by PBMs to favor, in some cases, favor an affiliated mail order pharmacy over a community pharmacy. So I know we're going to have a lot of discussion about this bill, and I know it's a lot of issues in the bill, but I think it's an important time for us to talk about it. And I'm willing to, I know there's going to be opposition, and I'm willing to work with the opponents as well as those of us that support it. And I'd ask for your support of the bill and turn it over to the witnesses.
Okay, it does occur to me before I call on your witnesses that with so much trouble with the U.S. mail system that is now systemic and structural and ongoing, and people taking 5 and 6 weeks to get first-class mail delivered to their homes, that maybe that aspect of what you're looking at is important. Okay.
It is. I think it is important. I don't think we're saying that that's always what gets pushed, but there are instances where the supporters of this bill and those that have brought it to me feel that it's very much pushed to try to do mail order as a priority. So, yeah, I think it's a very important issue.
Okay, we're starting with James Doyle. He is your lead proponent and has the 5 minutes, and all of the rest of you guys will have 2.5 minutes each. Okay, Mr. Doyle. You gotta unmute yourself. You gotta unmute yourself.
All right, can you hear me? Everybody hear me now?
Yes, we do, we do.
All right, again, Jim Doyle, I'm an attorney. I'm not a pharmacist, but I'm here representing the independent pharmacies of Maryland. These are the pharmacies that are locally, community-based, locally owned pharmacies throughout the state. Strongly support the bill. The bill for these pharmacies is extremely important because I think, as everybody knows, the independent pharmacies are struggling financially. Many have gone out of business, but even ones that remain in business are still continuing to struggle. And we'll have some witnesses after myself that will testify to exactly the kind of financial problems that they've had to deal with over the years. So there is a great need for this bill. At the same time, if you look at the pharmacy benefit managers, the PBMs, the pharmacy benefit managers are not struggling. As a matter of fact, they're rated among the most profitable organizations in the prescription drug supply chain. And in my written testimony, I cite to a Wall Street Journal article from 2018 that compares different members of that supply chain. The PBMs rate at the top of that chain in the article entitled Hidden Profits in the Prescription Drug Profit. prescription drug supply chain. So they're doing very well. On the other hand, the independent pharmacies are struggling and are not. One of the things that, of course, the PBMs are able to do as middlemen, it's been mentioned that they are middlemen. They deal with pharmaceuticals, they deal with insurers and MCOs, they deal with the pharmacies, cut contracts with all of them. In a way, if you think about it, when you've heard about in the past hedge funds and arbitrage, they're sort of like hedge funds dealing with arbitrage on Wall Street, where they have contracts on different products in different markets and are able to make money on the spread between those products. One of the things that is interesting about this case particularly, I think it was mentioned before, was the Rutledge decision, which was a Supreme Court decision that came out in December of this year. And that Rutledge decision dealt with, and I think this goes into the whole point of how PBMs deal with independent pharmacies. Arkansas enacted a statute which said that PBMs had to reimburse pharmacies in that state for at least the amount that pharmacies paid for the wholesale price of the drug that they dispensed. The PBMs, through PCMA, actually disputed and challenged that law. And that law went to the Supreme Court, which unanimously reversed the lower court decision, said that it was entirely within the province of Arkansas to regulate prices in that way, and reverse the position of the PBM. But the also interesting thing about that case is that Maryland, through Attorney General Brian Frosch, filed an amicus filing with the Supreme Court, urging the court to take the case, along with a number of other states. And in that filing, it points out that because PBMs own their own retail chain pharmacies and also own their own mail order pharmacies, there's a tremendous opportunity for self-dealing and for unfair advantages to be taken care of or taken place by PBMs. And that's what this bill is really trying to deal with. So we're trying to deal with those unfair advantages and the self-dealings that PBMs have routinely engaged in, as the Rutledge example is just one. So in this particular case, we have outlined 5 substantive issues that we think can help level the playing field and deal with those unfair advantages, those self-advantage programs. The first one and major one is spread pricing. And if you think about spread pricing, which is the practice where the PBM charges the MCO or the insurer one amount for the drug and the dispensing of the drug, the prescription, and pays a lesser amount to the pharmacy and profits the difference or pockets the difference as their own profit. This is a practice which it certainly may not be considered legally deceptive, but it certainly has a lot of those kinds of qualities and feelings about it. After all, the PBMs do nothing to dispense these drugs. They don't own the drugs. They don't dispense the drugs. They don't do anything. All they do is collect and profit the difference, the spread between what they charge the MCO and what they reimburse the pharmacy. And I think that's a huge issue that needs to be addressed in this bill. One of the other substantive arguments in this bill deals with the any willing pharmacy provider. And many states, by the way, already have this provision. And it simply says that pharmacies or the PBMs have to open the market to any pharmacy in a plan or that wants to get into a plan that's willing to agree with the terms and conditions that the PBM has negotiated for that plan. It's not asking for any special conditions. It's just saying, let us abide by those terms and conditions and let us into the plan. And of course, pharmacies or PBMs have every incentive to limit, to the extent that they can, members of the plan that that they have their own ownership or affiliations with, whether it's chain retail pharmacies or mail order pharmacies or whatever. This does away with that. By my last count on the internet, there were 35 states that have enacted some form of any willing provider, and many of those specifically deal with pharmacies and the ability of pharmacies who agree with those terms and conditions to enter those plans. The other substantive issues, just to be very brief on it, deal with the copays. There's no reason that copays should be different between affiliated pharmacies and independent pharmacies, just for the purpose of driving customers to the affiliated pharmacies. That should simply not be permitted. There's no reason that in terms of mail order, that there should be restrictions or requirements to use mail order, or that the Department of Health in the House letter said, well, you know, on the Medicaid side, consumers always have the right to go through a procedure to opt out of the mail order requirement. That shouldn't be required. Consumers should have the decision.
You're really going over time. Are you about to wrap up?
I'll wrap up. So we think in terms of the mail order provisions and also the DIR fees, which are these reimbursements for patient metrics that are not well understood even by the pharmacies. Those things all need to be dealt with in this bill to put things on a level playing field. Thank you.
Let me ask you, you gave us a couple of citations of literature. Could you get at least to Senator Reedy a hard copy of each of the three documents?
I mentioned a Wall Street Journal article. I
Let's say you
mentioned
talked about the Arkansas Supreme Court decision in which fraud
yes,
would file a brief.
and the amicus decision by
the Wall Street Journal article explaining the relationships and what, yeah. So those three, if you could do that.
I can get those all three to Senator Reedy. Yes.
Okay, thank you. Okay, any questions for this witness? Okay, we will go next to, where am I?
Number 3.
Okay, to Elnaz Diary. Oh, dodgy. Okay.
Honorable Chair and the members of the committee, good afternoon. My name is Dr. Darch, and I am a former owner of an independent pharmacy that just closed in Montgomery County, Maryland. I'm here to testify in favor of Senate Bill 615. PBMs must be prohibited from engaging in the practice of spread pricing. They must be prohibited from steering the business to the pharmacies that are preferred by them. All these actions create conflict of interest. All the unregulated activities they are performing should be considered unethical and immoral. As a result of their non-transparent actions, money is being taken away from the very little profit of independent pharmacy owners. Small businesses are the backbone of the United States economy. Destroying small businesses will destroy the economy. The inaccurate information that was presented by PBMs originally, and I heard some of those today in the previous Senate Bill 614, has given them leverage to control the pharmacy market. Currently, 3 PBMs own 75% of the market. They're not being regulated. The changes that are suggested by them are only filling their pockets. There's no financial savings or help to the state coming from them. I simply request someone initiate an act to regulate it and look at the reports they're claiming that they're helping taxpayers and the states. There's an independent study done by Stoffers and Myers in 2019. Please take a look at it. Just don't take my word for it. $70 million in 2019 was fleeced away from Maryland taxpayers. It's not accounted for. Our consumers and your constituents are also getting hurt by higher copays, higher premiums, and higher deductibles. I'm standing here with a very heavy heart, and I apologize in advance if I get emotional. I had to close my beloved pharmacy. This was due to decreased margins. I sold my pharmacy to CVS, sold my files to CVS, which happens to own the largest PBM in the country. For years, I worked very hard. I'm a proud naturalized citizen. I came to US pursuing my dreams. I opened and operated a successful business in a short period of time. and I operated it for 15 years. I am an example of what America is about and should be. My daughter has always been very proud of her mom and her accomplishments. Last week's conversation with her that mommy had to go out of business is by far the most difficult conversation of my life. I hope you will find it in your hearts to vote in favor of Senate Bill 615. Allow independent pharmacies to stay in business and serve your constituents with the utmost awesome healthcare they deserve. I want to address a couple of things that were brought up at Senate Bill 615, which unfortunately I wasn't fully prepared. I was not informed that I was testifying about Senate Bill 614. Couple of questions. My question for Mr. Johansson. He mentioned some of the claims they make money and some of them they lose money. I like to know how many claims the
You know what? You can't ask questions. The senator
okay. I want to
ask him a question later.
I want to know how many claims they like to lose money on. Certainly, as a business owner, no one would like to lose money. The reports they are referring to, I have no idea where they're getting their reports, but as far as I know, many independent pharmacies are forced to close. I don't see the trend of opening new independent pharmacies and an increasing trend.
You have educated us a lot. I wish we had more time for everybody.
I'm not seeing that trend. All these embauched and non-transparency and the claims they're making, and I'm not surprised to see one of them turning around and saying, it doesn't concern her how it's
okay, I'm sorry, but your time is up.
Thank you so much for your time. Please have it in your heart to vote in favor of Senate Bill 615. Thank you.
Thanks for your testimony. All right, we'll go now to Howard Modulagi.
Yes, can you hear me?
Yes.
Good afternoon, Madam Chair and the Senate Committee. I really appreciate you. I literally just got discharged from the emergency room not too long ago, but this bill was so important to me, I cannot miss it. I want to explain what is actually going on here. You see, there's a lot of false testimony that I give to the Senate from the PBM side, but I'd like to explain a few things that will show you why we're asking for your support for Senate Bill 615. So I want to show you two props to make it clearer. This one is saying average wholesale price plus a dispensing fee at a 20% discount. This prop is saying average wholesale price plus a dispensing fee at a 15% discount. When you put them side by side, the 20% discount sounds like a better deal, doesn't it? But what if I flip it this way? Now you can see that the difference in these contracts is that the average wholesaler price for the 20% discount is substantially higher. So even though it represents discounts upfront, but it costs more on the back end. That is the difference between independent pharmacies and PBM affiliated pharmacies. They claim they offer discounts, but when you flip it, you see the cost of the plan is actually more. That is why the state of Ohio saved $54 million by regulating PBMs. I'm sorry, $280 million by regulating PBMs. West Virginia saved $54 million by regulating PBMs. The job of a PBM is to transmit a claim. So they should be paid an administrative fee. But when you repackage the average wholesaler costs and you put it in what we call spread pricing, it allows you to make more money by changing the terms of what a medication actually costs. That is why the CMS asks pharmacies on a regular to provide this thing called NADAC. In the previous testimony in Bill 614, they told us it's a voluntary report. It is not voluntary. If I do not submit the actual invoices coming from the wholesaler, exactly what I pay, including the rebates, my Medicaid checks will be withheld. I don't have a choice. And because it's a factual data. It's not coming from the pharmacies. It is coming from the drug wholesaler, including any discounts that I may get. That is why it is important that they get it from me. And if they don't get it from me, I don't get my Medicaid checks. That is why NADAC is the only true, contrary to whatever they are saying, we are the ones in the stores. This is the only true indicator of what I'm actually paying for medication. So I just want to
Your testimony is very compelling, but you've run out of time.
I just want to thank you so much for giving me the opportunity. I appreciate you.
Okay. We're going next to Jennifer Bryman.
Hi, Jennifer Bremen. Good morning, Madam, or good afternoon, Madam Chair, Mr. Vice Chair, distinguished members of the committee. Thank you for this opportunity to speak with you today. My name is Jennifer Bremen. I come before you today representing the Maryland Managed Care Organization Association. MMCOA represents the 9 managed care organizations that serve the 1.3 million Marylanders enrolled in the Health Choice program. The MCOs come to you today respectfully opposing Senate Bill 615. As you will read in our submitted written testimony, and as you all know, the MCOs are regulated by the Maryland Department of Health with a focus on ensuring high quality care and cost effectiveness. While we applaud Senator Reedy's efforts, access and quality provisions, including recently enacted regulations, were adopted by MDH to improve the experience of pharmacists in the Medicaid program. We believe that this legislation may undermine those processes recently adopted by MDH to address pharmacists' concerns regarding participation in the Health Choice program. For these reasons, we respectfully urge an unfavorable report on Senate Bill 615. As always, the MCOs look forward to continued collaboration with the state as we work to identify ways to improve access to affordable, high-quality care for all Medicaid participants. Thank you all for your time.
Thank you. Are there questions? Okay, we're going then to Heather Cascone. You are muted. Unmute yourself.
My apologies. Thank you, Madam Chair, members of the committee. I appreciate the opportunity to raise some potential issues with Senate Bill 615, which provides a list of PBM practices that would be prohibited in the commercial market. First, I'd like to start with the bill aims to prohibit spread pricing. There are essentially 2 basic approaches employers or plan sponsors, the payers of the benefit, use to pay for the services their PBMs perform. One is a risk mitigating spread model or a pass-through contracting model. A spread arrangement provides plan sponsors with cost predictability by giving a price certain for prescription drug reimbursements to pharmacies. Very important to plan sponsors. As the payer of the prescription drug benefit, they have every opportunity to choose the pricing model that best suits their purchasing needs, and typically require PBMs like the ones I represent to submit bids for both approaches so that they can compare the pricing. Some employers and other plan sponsors choose spread to ensure predictability in knowing what their prescription drug costs will be. That's an important element of the prescription drug benefit for them, and that choice should be theirs to make. Second, the bill would create an any willing provider scenario for pharmacies, something that Maryland does not have in any other aspect of a health plan. Requiring plans to include any pharmacy in their network would increase costs for plans and ultimately for patients. Opening networks to an any willing provider standard reduces the overall volume of sales for all network pharmacies, ultimately resulting in smaller discounts. That's because pharmacies agree to be in network because they can depend on a predictably higher volume of store traffic, foot traffic, and sales. Increased sales mean that the pharmacy can then pass savings on to patients by setting lower product prices and or accepting lower dispensing fees while still being able to meet their bottom line. I appreciate the concerns raised by the previous witnesses about their reimbursement levels, and I believe that we all look forward to seeing the MIA finalize the rulemaking on regulations, a law that was passed by this legislature last year, providing for regulation of pharmacy services administrative organizations. These PSAOs work directly with network pharmacies in helping them to negotiate their reimbursement levels. And so hopefully that bill coming into law and effect will create some transparency for that relationship. We have a lot of other concerns on this bill, and so unfortunately we have to respectfully request and ought not to pass. I'm happy to answer any questions the committee might have.
Let me just ask if you think that well, I won't ask it right now. I'll just go on. All right, let me move on. We're going to Michael Johansson.
Thank you, Madam Chair. Just briefly on behalf of PCMA, this is Mike Johansson. I would note that the spread pricing contracts are between the PBM and the employer or insurance company. We don't have any employers or insurance companies, supporting this bill and this prohibition. The spread pricing contract does not apply to the contracts between the PBMs and the pharmacies. Secondly, just to cover, another issue in addition to what Heather mentioned, there is already legislation in the insurance law that passed many years ago that says PBMs and insurance companies can't provide incentives to use mail order or require mail order. So I think that piece in this bill is probably covered elsewhere and has been longstanding law. So, we understand this bill is complicated. It is further complicated by the recent Supreme Court decision. And I think, it's going to take some work perhaps over the summer, Madam Chair. If there are some issues that you believe should be reviewed, we'd be happy to participate. Things have gotten much more complex since that court decision that was referenced by Mr. Doyle. So we oppose the bill and we, happy to answer any questions.
Are there any questions? Okay, we're going to Matthew Celentano.
Thank you, Madam Chair and members of the Senate Finance Committee. I'm Matt Celentano here today on behalf of the League of Life and Health Insurers and America's Health Insurance Plans, or AHIP, in opposition to Senate Bill 615. The bill is fundamentally about a contract between a carrier and a PBM, and neither folks have asked for an intervention here. I just wanted to start with that. But as carriers, we would object to the removal of spread pricing. It is a tool that carriers use to save money and an option in the absence of directly lowering the manufacturer's prices. It's a tool we have to use. Besides spread pricing, the bill also eliminates tools that we also use to keep premiums as low as possible, like value-based purchasing, which focuses on things that create the best healthcare outcomes. We also oppose the removal or any willing pharmacy provisions that will drive costs. Frankly, some pharmacies are just more competitive than others. But lastly, and I think most importantly, is to get to the fact that prescription drug spend for carriers and to premium has exploded in the last couple of decades. Prescription drug spend in your premium is roughly about a third now. It used to be in the low teens. We're doing the best we can to control drug costs while list prices go up year after year after year. And this bill will just make some of those challenges even more difficult. So we ask for an unfavorable report on Senate Bill 615.
Okay, are there any questions? Senator Reedy.
Just very quickly, Madam Chair, and it's more of a general question. I think I'll direct it to Heather because Heather, I think, wanted to ask you this maybe on the last bill. But as a general question is, there's clearly some problems here, though, and trying to figure out some possible solutions. There's been a lot of talk from the opposition about spread pricing. Some of the other points of the bill about diminishing reimbursement to a pharmacy based on patient outcomes or people getting different copay fees if they're affiliated with the PBM or not, as far as being a part of if they're owned or part of the PBM's corporate structure. I mean, could you speak to whether there's some possible help and solutions there relative to the problems you've heard from sort of our side of the bill here?
I'm going to try to tackle that question. Thank you for the question. Let me first start by saying nobody has to hire a PBM. Employers, governments, big and small, the federal government, state governments, labor unions, all choose to work with PBMs because, as Mr. Celentano indicated, the rising cost of prescription drugs is increasing so rapidly that without an effort to mitigate some of that cost, a pharmacy benefit would become unsustainable. So nobody has to work with a PBM. It's completely a choice. What I think is happening here is that, there was some mention by previous witnesses about references to PBM profits comparable to reimbursement levels of the pharmacies. It's really easy to cherry pick some of these examples. I mean, my PBM members, many of whom are public companies or publicly traded, you could look up any of their financial information online and see that in comparison to the rest of the drug supply chain, PBM profits are relatively razor thin. They're somewhere between 3 and 4% in comparison to many of the other aspects of the supply chain, pharmacies, wholesalers, drug manufacturers making the most. And so, it's easy to kind of cherry pick those examples. And I also think it's somewhat disingenuous to share claims that indicate that pharmacies are getting reimbursed well underwater. I think we were trying to get into this discussion a little bit before about whether pharmacy stores are viable. It's within a PBM's purview and best interest to keep pharmacies open and viable. One of the main things that PBMs do and why employers and plans hire them to work together is to build networks of pharmacies. And if pharmacies don't exist, then patients don't get drugs. And so we have a vested interest in making sure that pharmacies are viable and that stores stay open. Net overall, though, pharmacies are doing relatively well. I think it's unfair to say that stores have closed without acknowledging that new stores have opened in their place, or that chain drugstores have, I think as one of the previous witnesses mentioned, have also popped up. Patient access remains extremely stable for the consumers, the patients in Maryland. I acknowledge that there are certainly aspects that we would be willing to sit down and talk to the previous witnesses about. There are issues that we'd be happy to talk further about. But to just share one side of the story, I think unfairly educates this committee.
Well, that's why I'm glad you all are here to share the side of the story. But it sounds to me like you're basically saying you don't really feel there's really a problem here. I mean, is that really?
I mean, to put a finer point on it, the National Council of Prescription Drug Programs, the NCPDP, which is a nationally recognized standard-setting organization, I think everyone would agree and stipulate that it's a very neutral organization, reports on the number of pharmacy stores in the country and at the state level. And over the past 10 years, the stores in Maryland, specifically independent stores starting in 2010, had a net gain of independent stores of 113 stores. That accounts for both losses in stores, closures, and also new stores opening. So that's not PBM or PCMA data. That's nationally recognized third party.
That's very interesting. That's helpful information. I think for me, I'm not just doing this and saying that we need to, it's a problem because some stores have closed, although certainly I don't want to see anybody closed. And I recognize there is a market element to everything. So obviously I don't believe in the government intervening to keep something open that's not working. But when you say that nobody has to use a PBM, a pharmacy has to work with a PBM. Otherwise they won't have anybody to work with, right? I mean,
the pharmacies.
Big clients to work with.
I'm sorry to interrupt.
Go ahead. That's fine.
Pharmacies, I think over time, the pharmacy market has changed a lot, right? Like I compare it often to the hardware store that used to be down the block in my hometown that got bought out and became a Home Depot, which is really unfortunate and I don't like to see. But what's happened in the pharmacy market is that independent stores have really had to evolve and become more sophisticated purchasers in order to stay viable. And they have done so in working with PSAOs. PSAOs are organizations that help independent stores aggregate their negotiating power with PBMs so that it's not just one
Let me butt in for a minute and just remind everybody, we need about a half hour to set up for voting and we got a long voting list for tonight.
I didn't mean to drag it out, Madam Chair. We can continue the discussion offline. So thank you.
I think you got a lot of useful information. We got good information on all sides. Okay, so colleagues, and at 5 o'clock, be in the committee room for voting.